विद्या प्रशस्यते लोके विद्या सर्वत्र गौरवा विद्या लभते सर्वम विद्वान सर्वत्र पूज्यते। अर्थात विद्या की पूजा हर जगह है, विद्वान का आदर हर जगह है।
On this beautiful morning, I, Dr. Ankita Singh, JR Medical Oncology, is pleased to welcome you all.
And myself, Dr. Preeti Minakshi, first year PG in Department of Radiation Oncology, SCI, IGIMS. A very good morning to all of you.
We are obliged to welcome our respected director, sir, honorable dignitaries, learned delegates, teachers, students on the occasion of first anniversary celebration of SCI OT.
And a brainstorming session on thyroid cancer update. Well,
Albert Einstein said, if we knew what it was we were doing, it would not be called research, would it? It is on the occasions like this we get opportunities to test our knowledge and understanding. We look forward to get an exposure about what the best of the brains have to say on this evolving topic of thyroid malignancies.
Ladies and gentlemen, moving further, it is time for us to begin with inaugural session. So, it will be my pleasure to invite the dignitaries on the dais.
I welcome our director, sir, Dr. Binde Kumar, to come up on the stage and take a seat. Sir, please come on the stage.
A big round of applause, please. I request Dr. Professor N.R. Vishwas, sir, Vice Chancellor, Sri Balaji Vidyapeeth, Pondicherry. He will be joining us as a chief guest through online portal. Sir, please.
A big round of applause for Dr. N.R. Vishwas, sir. He has joined through online portal. Now I request guest of honor, Padma Shri Dr. J.K. Singh, sir, Director, SS Hospital, Patna, to please come up on the stage and have a seat. A very welcome, sir.
Now I request our chief guest, Dr. Professor Rajiv Ranjan Prasad, sir, from Jayaprabha Medanta Hospital. Sir, please come on the dais and take a seat. Now I request our Dean Academic, Dr. Professor Vishnu Mohan Dayal, sir, please come on the dais and take a seat.
He will be joining us shortly. Now I welcome our Chief State Cancer Institute, IGIMS Patna, Dr. Rajesh Kumar Singh, sir, to come on the dais and have a seat.
A big round of applause, please. I request Principal IGMS, Dr. Professor Ranjit Kuha, sir, please come on the dais and take a seat.
Now I request our MS Professor Dr. Aman, sir, IGIMS Patna, to come up on the stage and have a seat. And now I welcome Dr. Manish Kumar, sir, in charge Surgical Oncology, SCI Patna, to come up on the stage and have a seat.
Now I request Dr. Bunty and Dr. Monroe, please come on a stage and present a bouquet and flower pot to our director, sir. हम सब आपका बहुत बहुत अभिनंदन करते हैं।
Now I request Dr. Monirul and Dr. Rana to come up on the stage and welcome our chief guest, Dr. Rajiv Prasad, sir. A very warm welcome to you, sir.
I request Dr. Raina and Dr. Fatima, please come on stage and welcome our guest of honor, Padma Shri Dr. J.K. Singh sir. I request Dr. Devapam and Dr. Bunty to please come on stage and present a bouquet to our Chief SCI, Dr. Professor Rajesh Kumar Singh sir. So we are pleased our Dean sir have just joined our session. Sir, please welcome.
A very warm welcome to you, sir.
I request Dr. Fatima and Dr. Raina to please come on stage and present a bouquet to our Dean Academic, Dr. Professor Vishnu Mohan Dayal sir. I request Dr. Raina and Dr. Monreal to please come on stage and welcome our Principal sir, Dr. Professor Ranjit Guha sir. Now I request Dr. Monreal and Dr. Devapam to please come on stage and welcome our MS sir, Dr. Professor Aman Singh sir. I request Dr. Raina and Dr. Fatima to come on stage and please welcome our Surgical Oncology Department in charge, Dr. Professor Manish Kumar Singh sir.
I would now start with the keynote session. मैं निवेदन करना चाहूँगी डॉक्टर राजेश सर, SCI चीफ, कृपया आप माइक पर आएं और वेलकम एड्रेस करें.
सर, अपने बहुमूल्य शब्दों से हमारा मार्गदर्शन करें.
एंड माफ़ी चाहूँगी, जैसे कि हमारी परंपरा है कि किसी भी शुभ कार्य से पहले हम दीप प्रज्वलन के साथ ही शुरुआत करते हैं. मंच पर बैठे आदरणीय गण कृपया लैंप लाइटिंग के लिए
आए और माँ सरस्वती की आराधना करते हुए दीप प्रज्वलित करें.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा. चढ़ायो अच्छा गजमुख को, चोंदिल लाल विराजे सुत गौरी हर को, हाथ लिए गुड़ लड्डू साई सुरवर को, महिमा कहे न जाए लागत हूँ पद को. जय देव जय देव जय जय जी गणराज विद्या संदाता, धन्य तुम्हारो दर्शन मेरा मन गमता. जय देव जय देव
seats. I would now start with the keynote session. मैं निवेदन करना चाहूँगी हमारे चीफ डॉक्टर राजेश सर, कृपया आप माइक पर आए और वेलकम एड्रेस करें.
Good morning again and warm welcome to all. Respected Director Sir, respected Dean Sir, respected MS, Dr. J.K. Singh, Dr. Rajiv Ranjan and online Dr. ex-Director Dr. N.R. Viswas, Principal Sir, all are warm welcomes with all faculties, HOD of the departments, students and friends. Today we are going to celebrate 1 year anniversary, you can say, 1 year of our ACI surgical OT. It was a great journey, our long journey from CTRC to RCC and ACI. And at present it is just, you can say, a state of art in our IGMS in this department. We have each and every facilities. There are 6 departments, that is surgical oncology, medical oncology, radiation oncology, gynae oncology, medical physics, pain and palliatives. So each and every facilities are available here for the treatment of cancers. And today our burning topics for thyroid cancer, that is really a challenging job for surgeons as well as physicians to treat that. So I think that you will enjoy these sessions nicely, and again hope each and everything will be, you will like that. Okay, thanks a lot.
Thank you so much, sir, to mark the start of today's program.
Now I request our Principal Sir, IGMS, Dr. Professor Ranjit Guha Sir, please come on stage and address a keynote.
Very good morning, one and all. Respected Chief Guest, Professor N.R. Viswas Sir online is connected with us, and Professor Rajiv Ranjan Prasad Sir, ex-Chief of this SCI, and our Guest of Honor Sir, and Director Binde Kumar Sir, Dean Sir, M. Dayal Sir, and MS in charge MS DDA Aman Sir, and Rajesh Ji, Chief SCI present, and Monish Ji, our in charge HOD of the Surgical Oncology Department. It is indeed a great pleasure for me and a very delightful moment to be a part of this very important event, because this is the celebration of the first anniversary of surgical OT, and those who are involved and those who have witnessed the whole ontogenic process of the transformation from CTRC to RCC to SCI, and the starting of the SCI OT against all odds. Actually that time N.R. Viswas Sir was the director, and he played the key role, and with the help of all the team members, our Dr. Monish, Dr. Shoshi and all the others, and Rajesh Ji was there, then Chief Rajiv Ji was there. So their industrious diligence, sincerity, commitment and conviction has made it happen. Now it is the state of the art in the national picture also, its name is there. So kudos, big round of applause and salute, grand salute for all these who have contributed enormously for this transformation and for this 1 year completed. Now our CIOT is working wonderfully in collaboration with all the other departments of cancer and other departments of IGMS. So you are an integral and important part of the IGMS family. The SCI family is also a very integral part, and most heartening to see that the celebration is not only done by a cake cutting, but when you see it is a celebration is done by a CME on a very pertinent topic of thyroid malignancy updates, and this type of updates always, you know, exchange, it offers a platform for exchange of ideas and share of thoughts, and opens up new channels of vistas and sharing of the information. So I think this is when the education research mixes with such type of celebration. That means that we have already tacitly spaced into the higher orbit. So now our target should be in the international level. So we are SCI department, we are very much proud of our surgical oncology. They have done a lot of difficult operations we have seen. So we are really very much grateful to them, thankful to them, and proud of them. So thank you very much for your patience, those who are present here, all the esteemed and audience and hallowed gathering in this early morning celebration. You have made the event very successful by your gracious presence. So thank you very much, and thank you all once again.
Thank you so much, sir, for your kind words.
I would like to invite Dr. Professor Aman Kumar Singh sir, our MS, please come on the stage and address a keynote for us.
Our respected Director, Professor Binde Kumar sir, Dean sir, Dr. B.M. Dayal sir, Professor J.K. Singh sir, Rajiv sir, SCI Chief, Rajesh Kumar Singh, Principal sir, and especially due to which we gather here for thyroid cancer update, Dr. Manish, who is my nice junior and colleagues. He is very sincere. We all know cancer itself is a very difficult to treat, but early interventions by surgery is one of the best method, but diagnosis generally occurs late due to lack of knowledge and other things. So we all enjoy this and congratulate to Manish again for 1 year completion of his OT, and especially congratulations to all. We all enjoy and get the scientific knowledge today by this update. Thank you, sir.
निवेदन करना चाहूंगी हमारे डीन सर डॉक्टर प्रोफेसर विश्व मोहन दयाल सर प्लीज स्टेज पे आएं और अपने बहुमूल्य शब्दों से हमारा मार्गदर्शन करें.
Good morning, everybody. Our respected Director, Dr. Binde Kumar, our special guest on occasion, Dr. J.K. Singh, Dr. Rajiv, who was with us now with Medanta, the Chief of the Principal, Dr. Ranjit Guha, Chief of SCI, Dr. Rajesh, MS, Dr. Aman, and the flag bearer for this celebration, 1 year of SCI OT, Dr. Manish, Head of Surgical Oncology. I must congratulate SCI and the department, especially the Department of Surgical Oncology, for organizing this event to commemorate 1 year of the opening of the surgical OT. It is so important to step back and then look at what we have achieved and find ways to improve and kind of reach greater heights. And I'm sure Dr. Manish, Dr. Shashi and other colleagues will sit together and reflect on that. But this occasion is the CME on thyroid cancer, a much neglected topic and most appropriate for this celebration. I'm sure all the delegates, all the faculty members who have gathered here this Saturday morning will learn much from the speakers and go back satisfied. Surgical oncology is a new specialty for us, and we are hoping in due time, short time, that we would start the DNB DRNB in surgical oncology, for which the formalities have been completed and we are just awaiting the order. So that will be another feather in the cap of surgical oncology and SCI. And I think the department is small, but they are very hardworking, and I congratulate them for their effort. I think if there are posts, we should expand the department because there's a vast need of cancer surgery which is unmet, and SCI being the apex cancer institute of the state must do all it can to meet this need. With these few words, I thank you all for gathering here to celebrate this event and the CME. Thank you.
थैंक यू सर, आपके प्रोत्साहन भरे शब्दों के लिए बहुत बहुत धन्यवाद। अब मैं बुलाना चाहूँगी हमारे गेस्ट ऑफ ऑनर पद्मश्री डॉक्टर जेके सिंह सर, एसएस हॉस्पिटल पटना। कृपया आप स्टेज पर आएं और हमें एड्रेस करें।
Chief guest of this occasion and Director of this institute, Binde Kumar ji, dignitaries sitting on the dais and off the dais. It's my great pleasure to be a part of this program. That is very important program, first anniversary of the State Cancer Institute. State Cancer Institute is doing a commendable job in the Medicare of the oncology and the cancer management. Oncocare was having a great problem before this institute came into the function, and now it is doing the great work, I must say. Even the private institutions, there are many in the state, but government sector, there was no person, no institution which could give a personalized treatment, or you can say treatment to the poor person. This is the only institute in this state which is for poor also, which is for the other persons also. So I really appreciate the past director of this institute, Rajiv, and the present director, Dr. Rajesh, under the dynamic leadership of Binde Kumar. Friends, last few decades, if you see the last few decades has tremendous advancement in the field of oncology. If we talk about the surgical treatment, there have been many refinements during the passage of time, and the techniques and the other things also related to surgery has greatly changed, has greatly enhanced. The concept has also changed. If we talk about the radiation treatment, with a better understanding of the tumor biology and tumor behavior, now we are in a position that we can treat the deep-seated tumor anywhere in the body with great accuracy without harming the neighboring structures. If we talk about the medical oncology, it has gone to a great height also, and after the immunotherapy, it has given a new shape in the medical management of the tumor. There are if you visualize many things, what is the future of oncology, if you can see? What is the future? I think there are 5 things which are really very important in the management of this future oncology. 5 things only. One is the personalized medicine, personalized vaccine, not medicine, personalized vaccine. Other is cell therapy. Third thing is the gene editing.
And the fourth thing is the biomarker treatment. These four things has really revolutionized the treatment. And I'm sure the cancer, which is a dreaded disease now, it is incurable, people were always saying. Now it will be in the curable cancer, curable disease list. It will definitely come in the few years' time. I think there is one thing also apart from the four things, that is the artificial intelligence. It has come in a big way. An entire world is focusing on that. The programming is done in the computer to mimic the human intelligence. I have gone through in this field, and something is being done in our Hajipur center, that is 300-bedded hospital. Artificial intelligence, we are in touch with the Duke University, USA. We are in touch with the Canada government, and at the same time, we are in collaboration with the ITI. All four organizations are meeting, and we have done something we have started, I must say, because it has a crucial role to play in the future, artificial intelligence. It will revolutionize the treatment. It will not only change the early detection, it will not change the classification, it will not change the histopathological aspect, it will not change the genetics, but it will change the molecular markers also. This is a great thing to play. And we have already been in the process in Bihar. I think within a few years' time, we'll give you something, what artificial intelligence will do in the management of cancer. So we are in the process of giving the name of cancer from incurable to it is in the cure list. It will come. Definitely it will come. I congratulate Dr. Rajesh to have this thyroid cancer. Generally we are talking breast cancer, lung cancer, prostate cancer, everything we have been talking. But thyroid cancer, it's a small percentage of the entire, scenario. It's a very small percentage. That's why I do not focus on that. But it is one cancer which can be cured, which can be given a full control. It can 100% control on this, if we can detect in an early stage. Detection is also not very difficult. Sometimes it becomes a tumor, sometimes it becomes without a tumor. We have to detect it. Once you detect it, you control it. Except one variety, that is undifferentiated variety. We can cure it. We should treat thyroid cancer, we should control it, we should cure it, and we should show to the public that cancer is curable. So this is one tumor, and I really congratulate Dr. Rajesh and his entire team to bring this particular tumor. And I was going through the scientific program. He has very much comprehensive scientific program has been given by him, and I think all the PGs must come, postgraduate must come. These should know what is cancer and what's the treatment going on, how we can, there are cancers, how we can cure the cancers. With these few words, I am really very much thankful to all the persons who are engaged in this particular program, and I really congratulate the State Cancer Institute person to bring such type of seminar, and I think this should go on. I was telling Dr. Rajiv also, you are also in a big center. Now if you people will come and do I think perceptions of the cancer will definitely grow from the mind of those person who thinks that cancer is incurable. Thank you once again.
Thomas sir, we are obliged to have you here. Now I welcome our director sir, a very dynamic personality to have on the stage. Dr. Vinde sir, please come up the stage and say some few words from your side.
Very good morning everyone and the audience on the dais, of the dais. Chief guest of the occasion, Professor N.R. Biswas, previous Director, IGIMS, now Vice Chancellor, Mahatma Gandhi University, Pondicherry, Dr. J.K. Singh sir, Dr. B.M. Dayal sir, Dean Academics, Dr. Principal, Dr. Ranjit Guha, Aman ji, Medical Superintendent, Rajiv Ranjan ji, the Director, Radiation Unit at Medanta, Rajesh ji, Chief, State Cancer Institute, Dr. Manish ji, the Health Department, Surgical Oncology, Dr. P.K. Jha, the Health Department General Surgery, Dean Examination, Professor Om Kumar, departmental member of the State Cancer Unit, Department State Cancer Center at Institute at IGMS, friends, ladies and gentlemen. This is the occasion where we are commemorating and celebrating the 1 year of completion of surgical oncology in the State Cancer Institute. The able leadership of Dr. Manish Kumar under the guidance of Rajesh ji and previously Dr. Rajiv Ranjan, who started the whole thing here, takes me for a retro trip to the Department of Cancer. I'm not going detail because there's no time to discuss all these things. But the surgical oncologist, we have worked together in the department. The stalwarts, my friend who is not here, Amitabh Singh, the first man was there, Dr. BP Singh, Dr. Sarkar, Dr. Goswami. I have seen people, the madam is not there, the Sangeeta Pankaj. We have been closely worked over a period of 17 years. And I am aware what problems and what hiccups they are facing. They are doing commando operations, they are doing total hippals, they are into APR resections, and all those things which are the domain for a surgeon, general surgeon to be proud of, was a natural and normal thing for these people in day-to-day work. So now I know the Manish ji and his team, Sasi Pawar and the PG, we are having DNB course from this time. We have, and I am hopeful that DNB will be given. I am not content with only DNB. I want one more faculty in department. I have asked them, and we want to start a AMD, DM, MCH course, full-fledged in surgical oncology. This is my aspiration and this is my intention, and I pray God to have this study program in the Department of Surgical Oncology in coming time. Surgical oncology as such, and we're discussing in the pretext of thyroid cancer, the update is all about what we are having the knowledge and where we are going. Professor Padma Shri Professor J.K. Singh has nicely summarized in very few points regarding the artificial intelligence, regarding the use of molecular biomarkers, regarding the use of the single cell diagnostic by quantum computing, and the last, if we go by just deliberating and giving the precision medicine by which we are going for individualized and tailor-made treatment to each and every individual having every type of cancer, saying this genetic pattern. Going back in the memory lane, when I was in Department of Radiotherapy back in 1990 at IMS BHU, there was a very good conference. What is the futuristic vision of the cancer in 21st century? And sir, the person is not here. Many of us have worked, done Professor K.T. Bhaumik, was very much ahead of time. And he was telling that, take 20 years from this date, and the treatment will be decided by the gene, by the chromosomal problems. And it was bizarre. Omji has very good association with Professor Bhaumik, who is now no more. Wherever he is, I pray for his peace to his soul. So everybody was, what sir is telling, this chromosome will play a role in the treatment. And now we know by the advent of this quantum computing, we are able to see what are the aberrations, what are the changes, subtle changes which has taken place in chromosome, and how these changes have given rise to this problem. And what we are talking about, the treatment of the gene itself, the genetic treatment, the whole concept of genomics, medical genomics which have come here is based on this. So these things which started in late 90s is now a reality in 23. I am very much glad the four persons from Department of State Cancer Institute, and namely Dr. Dinesh Kumar, sitting here in the audience, Dr. Richa Madhavi, Dr. Shraddha, and Dr. Kunal. They are working in tandem in artificial intelligence in the treatment of cancer and mostly in radiation. The paper you've shared, Dr. Dinesh, I've gone through the paper and this is eye-opener. Because simple thing is this, if we go in the details, there are two realities. If you go, the reality we are having, and then we go with the digital one, we have binary number 0 or 1. But there is another one, between 0 and 1, there are so many options are there. 0, 0, 1, 1, 1, 0, and anything. And that makes the quantum. It was difficult to start with, to do this computing with the manual method or the traditional computers we have. But with the advent of this quantum mechanics and taking the application and benefit of quantum application, we are now in the position of doing those all algorithm, the difficult algorithm and complex things into a very simple one. It is said that the Gopiya and Krishna, there is one Gopiya and one Krishna. How can you have the Ras Leela with 365 at one time? This was something which was in the myths and our scriptures. But this is now reality. If you go and do the quantum computing, you can know we can have so many realities in between the 0 and 1. So the 0-1 binary number has gone into that detail and that much spread has taken place. So we are exploring those areas which were mysterious and which were not known to us. So we are in that area now and we are doing it. I am pretty sure with the young bunch of doctors we have, we shall explore many new things in the coming time. And I again congratulate Department of especially the Surgical Oncology and State Cancer Institute in totality for organizing this meeting and having such a good update on thyroid cancer. Thank you very much.
Thank you so much for your words, sir.
Now, I would like to request a very humble personality among us, Dr. Rajiv Ranjan Prasad, sir, Director from Jayaprabha Medanta Hospital. Please come on a stage and address a keynote.
Director, Indira Gandhi Institute of Medical Sciences, Professor Dr. Binde, Padma Shri Dr. J.K. Singh, Dean, Indira Gandhi Institute of Medical Sciences, Dr. Dayal, Principal, Medical College, Dr. Ranjit Guhaji, Chief of SCI, Dr. Rajesh, Medical Superintendent, Dr. Aman, and Head of Surgical Oncology, Dr. Manish Kumar. At the outset, I would like to say that it is an honor and pleasure to be here. An organization which created my own identity, I still believe or I still feel that I'm part of this very organization. First of all, I would like to congratulate Dr. Rajesh, Chief of SCI, and Dr. Manish and his team, and the faculty of SCI and others for successfully completing 1 year of the initiation of operation theatre of surgical operation theatre, surgical oncology operation theatre at SCI. We have currently, as I was told, that we have 2 operation theatres which are type 2 surgical operation theatre running, and we have scope for another 2 which will be shortly completed. And I take this opportunity to take the promise of director that it will be done soon. I hope, being a surgeon, it should be close to his heart, and I'm sure this will be completed. many of you are not aware that Indira Gandhi Institute of Medical Sciences is the first organization in Bihar to have surgical oncology department. Dr. Amitabh, as Dr. Binde alluded to, he was the chief of the surgical oncology. He joined as assistant professor. He was senior resident, and then this department was started. Many of you talked about the developments that will drive the cancer mission ahead. And of course, to this extent, artificial intelligence, gene, and so many things will happen. And they will definitely contribute. But I am still convinced that one thing is far ahead of that is our own commitment. There are a lot of things available, but if you don't use them, if you are not willing to adopt them, you will never grow. So most important thing is to adopt all these things. First of all, you must dream of a center. You must dream that it should be a comprehensive center. You must dream that you will do something which is worthwhile. And that is exactly we did. Dr. Rajesh is witness to that. We started which is today known as SCI, a small department with one cobalt machine and with so much of a struggle. But I'm telling you, with my core of heart, it was always a pleasure. It was never a burden. And with everybody's cooperation and some of the names, the previous directors, Professor N.R. Viswas, Dr. Binde, and biomedical engineer, the engineering department, everybody cooperated. So things started falling in line. And that's how we grew. And I'm sure if you look at in the current perspective, the cancer cases are rising. As of today, we have 18 million or so, 20 million cases, which is going to increase to about 30 million by the year 2030 or 40. So we need to be prepared for those years. It is another tsunami that is going to come, or it is actually, it has come, but it's, the waves are building. So that is why we have to be prepared. And those sitting at the highest chairs, it is their responsibility to make the government aware about this, and we need many more centers. Let me give you a simple example. If you go by WHO recommendation, for 1 to 2 million population, you need one radiotherapy machine. And if you take Bihar's population as 120 million, then we need 120 machines as of today. And this is going to increase because cancer is increasing. So as of today, we need 120 machines. And how many of us, how many machines we have? Maybe 10 or less than 20, or it is about 10. So there is a huge gap. But this should not, prevent us from doing what we want. Like we have 10 machines. If you run it in two shifts, it becomes 20. If we run it in 3 shifts continuously, it becomes 30. So that is how you have to, plan your services and include. And one more important thing is that integration among the cancer centers. There's no point in holding patients and giving them a waiting list. If you see that there is a waiting list, you can always refer the patient to another center. And this is important because patients on waiting list, you are converting them from early stage to an advanced stage where treatment becomes complicated, costly, and not cost effective. So this something morning we were discussing, we must have an integration among various cancer centers, at least in a state, so that we can freely refer them to one center to the other. I congratulate Dr. Manish for selecting today's topic on thyroid cancer. This is one cancer which happens in both the genders, but 70% of thyroid cancers occur in women. And another interesting fact about thyroid cancer is that it is constantly rising in incidence. And for some reason we don't know, some of the countries have recorded a phenomenal increase in number of cancer cases of thyroid. For example, South Korea, there has been a huge increase in number of thyroid cases. This is one cancer where you have at one end a very benign cancer which you don't even need to treat sometimes, to another spectrum where you have one of the most aggressive cancers known to humankind. For example, anaplastic thyroid is highly aggressive. In fact, as an oncologist, if you ask me, I fear three cancers. One, anaplastic thyroid, glioblastoma multiforme, which is a brain tumor, and third is pancreas, mostly. So it is important that we discuss all these things, and things are changing. You know, over the period of time, the management of thyroid cancer has tremendously changed. A lot of targeted therapies have chipped in. The surgical skill has improved. The follow-up criteria have changed. And the radioiodine that is being given, the doses have come down, and it is much more safer now. So with all these things, I once again congratulate the SCI team, Dr. Rajesh and Dr. Manish and other faculty who have been here working very hard to take it to another level. So with these words, I once again thank all of you for being with us. Thank you very much.
Thank you, sir. Very short, Dr. N.R. Vishwas will be joining us. Till then, I would like to call Dr. Manish Kumar, in charge, Department of Surgical Oncology. Please come on the stage and enlighten us with your valuable words.
A very good morning to all of you. Respected Director, sir, our Chief Guest, Rajiv Ranjan, sir, N.R. Vishwas, sir, who will be joining shortly on the Zoom meeting. Oh, he has already joined. Our guest of honor, Padma Shri Dr. J.K. Singh, sir, our Dean, Principal, sir, Chief, sir, M.S. Aman, sir, and our colleagues, faculties, and the residents who has come to attend this ceremony of the first year celebration of the SCI-OT and the thyroid cancer update. Today, it is a proud moment for our State Cancer Institute and IGMS that the SCI-OT has completed 1 year of its journey. We have started the first procedure in the SCI-OT on 12th July 2022, and now in 1 year we have performed more than 500 major cases in that modular OT. At present we have 2 modular OTs in which both the department surgical oncology and gynecological oncology patients are being treated. But as we see nowadays that the cases are increasing day by day. When I joined in this institute in 2017, at the time of interview, the then director N.R. Vishwas sir has asked me that if you join here, you have a big responsibility of starting the SCI, because at that time the future project of SCI was in his brain, and he has said that if you join, then the whole surgical oncology department will be on your shoulders. So then I accepted the proposal and said that yes sir, I will join, and from that time I saw the journey, how I started the surgical oncology department from one room to now this state in the state of State Cancer Institute. And I would like to inform you that there is a space available in which 2 modular OTs can also be prepared, and with the assurance from our director sir, we are going to start the proposal of bringing up the 2 modular OTs in the State Cancer Institute. At present in SCI, MD radiotherapy course is running on. There is 1 seat of MCS gynecological oncology is also there. and we have applied for the DNB surgical oncology course, and with the kind help from our director sir, we are very much in process of gaining that seat. And it will be a big achievement for us because we will get the hands, and at that time the surgical work will also increase. And the second thing is that we have thought that we have to conduct a CME on a very common tablet, which is not very common, but its treatment is quite tricky. Just like thyroid cancer, it is a cancer which is very easy to treat, and sometimes it becomes very difficult to treat. So the main focus on this cancer is that it has got a very good prognosis. If we diagnose it earlier, either by any method, and we go on the proper management, then we can make the patient disease free of this disease. It has got such a good cancer. By these words, I thanks once again to all the dignitaries and the faculties and our colleagues who has joined this event, and I especially thank Dr. Rajiv Saran, who has come from Kolkata to attend this meeting, and he will give the video lecture on minimally invasive thyroidectomy. Thank you.
मदद करना चाहूँगी ऑनलाइन पोर्टल से जुड़े रिस्पेक्टेड डॉक्टर NR विश्वास सर टू हैव अ फ्यू वर्ड्स एंड एड्रेस आवर गैदरिंग वी वेलकम यू सर
Sorry. It is totally different field, but I was listening in between the talk of your director, Dr. Binde, and now Dr. Rajiv, and finally Dr. Manish. So, at the outset, I congratulate Dr. Rajesh and Dr. Manish and the team for update of this thyroid cancer. I will not go in detail about the nitty-gritty of this because a lot of speakers you have arranged from the country, from Calcutta, our local, from STI, and in the podium I see Dr. G.K. Singh, Padam Shri, and Dr. Manish, MS, Aman, and of course Rajiv and Rajesh and Manish. So thank you very much for calling me. There is a lot of interruption in online. So I was listening that 500 cases you have completed. Manish, congratulations to you. And during my time I have completed 2 modular OT, but the work is not yet completed. The 2 other is still to complete. I request Dr. Binde to finish that work because as the numbers are increasing, so at the earliest to complete that 2 more modular OT, and I request to start NCI course also at the earliest, so that a lot of cancer surgery will be completed there, and the more manpower you get, see the more number of cases you can complete. And I'm coming next month. I will visit your SCI, and always my blessings, my good wishes for the State Cancer Institute. We know with a lot of hardships, with a lot of challenge was there when we have started that. I will not go in detail. It was known to all, but after all we won and we made, we planned, we aimed, and we got it. Thank you very much for calling me, and I came from the meeting just to address you. I have to attend another meeting here, a lot of works here. Being the Vice Chancellor, it's too many works. Thank you very much for calling me.
आभार सर, आपके शब्दों में हमेशा हमारा मार्गदर्शन किया है. थैंक यू सर.
अब मैं बुलाना चाहूँगी स्टेज पर डॉक्टर बेबपम एंड डॉक्टर बंटी, एंड प्लीज कम अप ऑन द स्टेज विद द शॉल एंड मोमेंटो. And I request our director sir to please felicitate our guest of honor, Padma Shri Dr. J.K. Singh sir, and to please provide a memento. A warm welcome to you sir. May we have a round of applause. Now we request our director sir to please felicitate our chief guest Dr. Rajiv sir, and we welcome you sir. Thank you so much sir. And now I request our dignitaries to please have a respective seat off stage, and we'll take 5-minute breaks and then we'll start our academic session soon. Thank you.
भारभूता मनुष्य रूपेण मृगाश्चरन्ति, अर्थात जिस भी मनुष्य में ज्ञान नहीं है वो मनुष्य धरती पे चरने वाले जानवर के अनुसार है। सो ज्ञान हमेशा पूजनीय है। अगले सत्र की शुरुआत करने से पहले
अब मैं इस कार्यक्रम में आगे बढ़ते हुए पहले सत्र की शुरुआत करती हूँ। मैं अभिनंदन करती हूँ हमारे चेयरपर्सन्स का कि वो स्टेज पर आए। डॉक्टर पीके झा सर, एचओडी जनरल सर्जरी IGIMS,
डॉक्टर ऋचा माधवी, एडिशनल प्रोफेसर इन डिपार्टमेंट ऑफ रेडिएशन ऑन्कोलॉजी SCI, प्लीज कम ऑन स्टेज एज अ चेयरपर्सन।
डॉक्टर प्रीतेश कुमार सिंह सर, सीनियर कंसल्टेंट सर्जिकल ऑन्कोलॉजी, महावीर कैंसर संस्थान।
डॉक्टर आकांक्षा वाजपेयी, सीनियर कंसल्टेंट एट पारस हॉस्पिटल।
A very warm welcome to all of you, sir and ma'am.
So this is start of our first scientific session. I would like to call our first speaker on the topic of surgical anatomy of thyroid, Dr. Tashbihul Azhar, Assistant Professor in Department of Surgical Oncology at AIIMS, Patna. Sir, please come on dais and
shall be speaking on surgical anatomy of thyroid gland. Why this slide is not moving? Before we start anything to discuss regarding thyroid and thyroidectomy, let us pay our tribute to this great medicine physician, Mr. Theodore Cocker, for his innovative techniques in thyroid surgery. He is known for reducing the complication and mortality of thyroid way back in 1912. And we know him now, we remember him now by other ways like Cocker instrument, Cocker incision, Cocker surgeries also. At the outset, I would like to discuss few attributes of a good thyroid surgeon. First of all, a thorough knowledge of anatomy is of utmost importance. I mean, one cannot think of doing thyroid surgery without the thorough knowledge of anatomy. It's not only the safety of recurrent laryngeal nerve only. It's also the safety of superior laryngeal nerve and preservation of all the 4 parathyroids. At least 1 or 2 parathyroids should be safeguarded. Second is the understanding of physiology, that is the TSS suppression, which is often needed in post-op cases, and calcium metabolism and replacement. Mind you, it's a big morbidity. Post-operative hypocalcemia is a big morbidity, and that can very well prolong the hospital stay. A good thyroid surgeon should have the abreast of recents. What are the recent guidelines and how to approach a thyroid patient? And the final point is importance of training. Importance of training, why I say the importance of training, because it's the mentorship which makes you a good thyroid surgeon. where you have received the training, the usage of the modern energy sources like harmonic devices and the advanced bipolar devices. Everything that goes to make a good thyroid surgeon. Few slides regarding the development of the thyroid. It starts in the 5th week of embryonal development, and we can see it as the development actually starts from the primitive pharynx. Primitive pharynx is nothing but endoderm. Pardon?
स्लाइड सेव नहीं है सर, सॉरी फॉर डिस्टर्बिंग.
From the pharyngeal arch, that is the from the foramen cecum, the median enlarge that descends down in the 5th week, and it descends down and rests in front of the trachea, say around at the level of tracheal cartilage 2nd and 3rd. That corresponds with the C5 to T1 vertebral bodies. This is the from the foramen cecum, the thyroglossal duct that arises and descends down and is for the medial anal-arch. Later, it is joined by the neural crest cells, which is in the ultimobranchial body, that forms the lateral anal-arch, and that is the part of the 3rd arch. So median anal-arch, which is joined by the lateral anal-arch, that forms the complete thyroid gland. In each and every slide, I will try to give the clinical significance. What is the clinical significance of this embryonic development? The clinical significance is the point where the median and the lateral anal-arch joins. That point becomes prominent in the adulthood, and that forms what is called as the tubercle of Zucker-Kandel. Henceforth, I will use the term ZT instead of tubercle of Zucker-Kandel. General topography, everybody I think should be familiar here. It's like a shield which is covering the front of the trachea, and the 2 lobes are there which are joined by isthmus. The isthmus, which gives a slight cranial projection, which is called the pyramidal lobe. The entire assembly is corresponding with C5 to T1. Posteriorly, there is an attachment with trachea which is called as the Berry's ligament. I will come later in the slide how it is formed. It weighs around 30 grams. The weight is slightly on the higher side in female group. And as I mentioned, there is a ZT in the posteromedial aspect. Now the capsule of the thyroid gland. It has true capsule and a false capsule. One can see the true capsule. True capsule is what? True capsule is condensation of connective tissue around the thyroid. It is actually the part of the thyroid. It gives septa in the substance in the parenchyma of the thyroid. So it is actually a thyroid with its connective tissue surrounding it. Above that, true capsule is the false capsule. False capsule is nothing but a part of pretracheal fascia, some adipose tissue, some connective tissue which has condensed. It is the false capsule which gets thickened posteromedially to give rise to what is called as the Berry's ligament. Now in this slide, the clinical significance. Why I am mentioning this false and true capsule? The clinical significance is our plane of dissection is in between the true and false capsule. Why? The significance is mostly the parathyroid gland lies between the true and false capsule. At least this statement is true for the superior parathyroid gland. Okay? Coming on to the vascular supply, thyroid is one organ which is highly vascular. It has blood supply per gram of tissue which is I think the highest, I think next to adrenal gland only. And the vascularity further increases in cases of some pathology like toxic goiter, toxic multinodular goiter, hyperthyroidism. So in this side, what is the clinical significance of this vascular supply is hemostasis becomes integral part of thyroid surgery. One has to be very cautious while doing the operation. At each and every point, hemostasis has to be there, keeping in mind that it is a highly vascular organ. So what are the what are the vessels which are supplying this thyroid gland? We have, let us go back we have superior thyroid artery, inferior thyroid artery and thyroidema artery, 3 arteries basically. So let us go back. We have a superior thyroid artery which is a part of, which is the first branch of external branch of carotid artery. So it actually originates from the carotid system. Second is the inferior thyroid artery. Inferior thyroid artery is actually a branch of thyrocervical trunk, which in turn is a branch of first part of subclavian artery. Third artery is thyroidema artery, also called as the highest thyroid artery, which is found in 10 to 17% of cases, and it directly originates from the arch of aorta. So we have 3 arteries, one artery originating from the carotid system, one artery originating from the subclavian system, and a third artery which is originating directly from the arch of aorta. Similarly, this is the posterior view. Why I am put this picture, because one can note even the posterior aspect. There is a good arcade of anastomosis between the superior and the inferior thyroid artery. The superior thyroid artery often gives one posterior branch also. Once again, superior thyroid artery often gives one posterior branch which anastomoses with the ascending branch of the inferior thyroid artery. The clinical significance of this part. The clinical significance, whenever we are dissecting the Berry's ligament of trachea, we often, I should not use the word often, rather we consistently encounter one bleeder over there. And often, and it is a very notorious, if it gets damaged, then it bleeds heavily, and it bleeds at a point where recurrent laryngeal nerve is entering the larynx. So the clinical significance is that to secure that artery is utmost importance to safeguard the recurrent laryngeal nerve. Okay, both the superior and inferior parathyroids are supplied by inferior thyroid artery, that is up to cases of 90%. Veins, we have corresponding veins. We have superior thyroid veins, middle thyroid veins, inferior thyroid veins. Superior thyroid vein goes to the internal jugular, middle thyroid also goes to the internal jugular, and the inferior thyroid vein, it goes to the left brachiocephalic system. Middle thyroid vein, traditional teaching is the first vessel to be ligated in thyroid surgery is middle thyroid vein, but that is not the case always, as it is present only in 60 and 70% of cases, and maybe the percentage may be slightly lower because we do not often encounter middle thyroid vein. So what is the clinical significance when middle thyroid vein is present? Clinical significance is that there are 2 ways to approach thyroid gland while doing surgery. We can approach a thyroid gland through a midline, separating the strap muscle, or through a lateral approach, make a plane between the strap muscle and the sternal cleidomastoid muscle. So when we are approaching a thyroid through a midline, which is often a case when most of the surgeons they do this, the lateral approach is done only when we are doing a redo surgery where a central scar is there. So the significance of middle thyroid vein is that first of all it will stop the retraction of thyroid further medially. Second, it's a small vein, so ligation has to be proper. It can detach from the internal jugular vein and it can cause intra-op as well as post-op bleeding. Third is the lymphatic drainage. Lymphatic drainage, there are multiple classifications, lot of classifications are there. I am keeping this classification which I find the simplest. See, we have a chain, the jugular chain right from level 2, level 3, level 4. Apart from that, we have a central compartment node. Central compartment node may upper part, that is the Delphian, that is the prelaryngeal node, and lower is the pretracheal nodes. So median superior drainage, that is this part of the thyroid. Okay. Median superior, when I say part of the isthmus and part of the medial aspect of the lateral lobe of the thyroid, that basically goes to the prelaryngeal, that is the Delphian node. Median inferior drainage, that goes to the pretracheal and brachiocephalic node. Then right and left lateral drainage goes to the jugular chain, and posterior aspect of thyroid, the nodes along the recurrent laryngeal, they drain it. Innervation is very simple. Vagus gives the parasympathetic fibers, and inferior, middle and superior ganglia gives the sympathetic fibers. Now one of the most challenging part during thyroid surgery is to recognize the parathyroid gland particularly for the beginners. So the surgical anatomy which should be kept in mind while doing the thyroid surgery to safeguard the parathyroid gland is, first, color is there. Yes, color is there. One cannot undermine the color status of the parathyroid. It is yellow, but it's slightly towards brown, brownish yellow. Point number one. Point number two, one can dissect the hilum of the parathyroid also, because it receives blood supply from inferior thyroid artery. One can dissect the branches of the inferior thyroid artery and goes to the hilum of the parathyroid gland and safeguard it. Third point is that the location. Previously I mentioned in the embryology the development of ZT, that is the Zucker candle tubercle. The ZT can guide you at least the safety of superior parathyroid. It is in the upper and middle aspect of the superior parathyroid, located in the upper and middle aspect, and it's slightly superior and in the 1 centimeter circle. So these are the few points which one should remember to safeguard the parathyroid gland. Now one important thing is the relation between the recurrent laryngeal nerve and inferior thyroid artery. The first three sets of, that is the diagram number 1, 2 and 3. This is the these three diagrams are pictorial representation of recurrent laryngeal nerve in relation to tracheoesophageal groove. 4, 5 and 6, these three diagrams, they are representing the relationship of RLN with ITA. So we can see mostly it is lying posteriorly. Usually 2 to 3 branches of inferior thyroid artery is encountered, and in 50 to 60% of cases it is posterior to the inferior thyroid artery and in the tracheoesophageal groove. In between the branches we can have 5 to 10%, and anterior to the artery we can have in the range of 40%. See, there can be multiple variation in the course of recurrent laryngeal nerve, both right and left side. Recurrent laryngeal nerve is a part of the vagus nerve. In right side, it hooks around the subclavian artery and then goes towards the tracheoesophageal groove. So it has a course, say around 45-degree angulation is there when it crosses the root of the neck, and then it goes in the tracheoesophageal groove and then ascends and pierces the and then goes to the larynx. So the presence or absence of right subclavian artery also adds to the variation in the course of the recurrent laryngeal nerve. So when there is aberration in the arterial anatomy of right subclavian artery, then the right recurrent laryngeal nerve, that becomes non-recurrent laryngeal nerve. So that is also the case in less than 1% of the cases. Similarly, the left recurrent laryngeal nerve, it arches around the arch of aorta, or better to say the ligamentum arteriosum, which is slightly deeper in the thorax, and then it ascends upward and then it goes in the tracheoesophageal groove. So it is slightly having the straighter course as compared to the right recurrent laryngeal nerve. Again, it can also be a non-recurrent in case of situs inversus. So these two slides I discussed the relationship of recurrent laryngeal nerve is with inferior thyroid artery, and this is the slide wherein the superior thyroid artery and the relationship with external branch of superior laryngeal nerve. This is called the Cherny classification. We take a zone, we define a zone, say around 1 centimeter in the vicinity of the superior thyroid pedicle. Type 1, if the ESLN, that is the external branch of superior laryngeal nerve, is beyond 1 centimeter boundary of superior pedicle, then it is the type 1. If it is within 1 centimeter, then it is the type 2A, and if it is below the superior pedicle, then it is the type B. This is called the Cherny classification. More than equal to 1 centimeter, then type 1. Type 2 is less than 1 centimeter, and below it is the type 2B. Now, when it is a type 2A, that is within the 1 centimeter domain, then the chances of damaging the nerve is high. So we have a traditional teaching of ligate the superior pedicle very close to the thyroid gland and ligate the inferior pedicle away from the thyroid gland, but that is not true. Currently what we are doing, yes, we are dissecting both the nerves, superior laryngeal nerve and identify the recurrent laryngeal nerve also. In the process we dissect for inferior thyroid artery, we dissect the branches separately, and then individually we ligate the branches of the inferior thyroid artery, while superior thyroid artery, only when we are sure that we have safeguarded the external branch of superior laryngeal nerve, then only we ligate the superior thyroid artery. Now few points regarding the tubercle of sucker candle, that is the ZT. As I mentioned in the embryology, it is the fusion of lateral anallage and medial anallage where the fusion that projects and it forms the organ of ZT. So it's a Palezo classification wherein no projection, we can't see any projection in the thyroid gland posteromedially, then we can say ZT is not recognizable. Minimal projection less than 1 centimeter, then we say it's a minimal site ZT. In the figure 2, that is type 2, it's the projection is about 1 centimeter, so the ZT is of about 1 centimeter, and that is the most common variant of ZT. In third, it is largest. What is the clinical significance of ZT? As the size of ZT grows, recurrent laryngeal nerves keep shifting laterally. So in case of type 3, recurrent laryngeal nerve is very much lateral to the main thyroid gland. One can see the relation of ZT with recurrent laryngeal nerve and superior parathyroid. It is one of the important anatomical landmark to dissect and identify and safeguard the superior parathyroid and the recurrent laryngeal nerve. This I have already discussed, non-recurrent laryngeal nerve. Now triangles in thyroid surgery. Triangles are very important because apart from textbook, in real world when we are doing the surgery, we often try to mark few anatomical boundaries where we as a surgeon we feel we are safe, and there are few boundaries where we feel we are not very safe. So first I am discussing is the Behr's triangle or the Riddle's triangle. Behr's triangle is a triangle which is formed superiorly by the main body of the inferior thyroid artery, which is going towards the thyroid gland. The superior boundary is the inferior thyroid artery. Laterally it is bounded by the carotid sheath, and the third arm is formed by the recurrent laryngeal nerve only. So when we have identified the main trunk of the inferior thyroid artery that lies the superiorly, and when we are sure that when we have identified the carotid sheath, then the third limb is naturally the recurrent laryngeal nerve. Second, it is also called the Riddle's triangle. Second is similar triangle nearby, that is called the Lodi's triangle. Lodi's triangle is the third limb is formed by the midline. So like in Behr's triangle, the limb, one of the limb is formed by the recurrent laryngeal nerve. But in Lodi's triangle, the recurrent laryngeal nerve becomes the content of that triangle. Then second triangle is the Joll's triangle. Joll's triangle, one can see the picture here, Joll's triangle. Joll's triangle is the superiorly it is formed when we do a thyroid surgery, we retract the strap muscles. The superior boundary is formed by that retracted strap muscle. Medially it is formed by the midline, and inferiorly it is the superior pole of the thyroid. Superior pole of the thyroid or maybe the superior pedicle. If it is the superior pedicle, then the content of this triangle is external branch of superior laryngeal nerve. It is the superior. If it is the superior pole, then one of the lower boundary can be formed by the superior laryngeal nerve and the superior thyroid artery. So of significance is Behr's triangle, Lodi's triangle, and this triangle of Joll's. One is the triangle of concern also. Triangle of concern is the middle part, where we have we think that it's a maximum vascularity in context when middle thyroid vein is present. When middle thyroid vein is not there, then triangle of concern loses its importance. Why? Because in this triangle we will find middle thyroid vein crossing, ascending branch of the inferior thyroid artery and descending branch of the superior thyroid artery. So it's a converging point of all the most of the vessels going there. Apart from that, there are some cricothyroid space that is not needed here. Now, when in less than 1% of cases we have a non-recurrent laryngeal nerve. So, in which area one should recognize that non-recurrent laryngeal nerve? First of all, we try to dissect again the Bias triangles or the Lawrence triangle. If you don't find recurrent laryngeal nerve, then that should ring the bell that recurrent laryngeal nerve is not there and something is wrong. One should think of non-recurrent laryngeal nerve, though the incidence is less than 1%. So this unified area of danger, that is superiorly bounded by the superior thyroid artery, inferior by the inferior thyroid artery, and laterally by the carotid, and medially by the midline or the trachea. In this quadrangular space, one should try to dissect the non-recurrent laryngeal nerve and any structure which is passing from lateral to medial side, that constitutes the non-recurrent laryngeal nerve. Thank you.
Good anatomical basis of the thyroid disease, and also you describe the anatomical basis of clinical signs and symptoms. That is, our students are doing the examinations of the thyroid. So it is good presentation.
Any question from house?
Maybe around 20% of patients will have type 2B and type 1 will be in around 20%.
Yes, sir.
So most important point in this hernia classification is you damage most of the time when it is below the superior thyroid pedicle where it enters the thyroid, superior pole of thyroid.
Okay.
So if you don't identify in those cases, then you can injure the superior external branch of superior larynx.
Basically, sir, it's the dissection of superior pedicle which is very necessary to identify the external branch of superior laryngeal nerve.
Very nice presentation, Dr. Thank you for getting us through all those revisions. Just two quick comments. One is, I will talk about the clinical aspect. One is that when you try to preserve the superior laryngeal nerve, what we do is, we get hold of the superior pole and try to pull that laterally and down. So that separates your vessels from the nerve. So that's one maneuver we should be always doing. Even for the lower variants which come down, you will mostly find they get separated from the first point. And second point, for a non-recurrent laryngeal nerve, what you should look for is in your pre-operative CT scan if you have done. There you will find that the aberration occurs because the right subclavian doesn't arise from its common point and it comes from the arch. I mean, I don't remember exactly, but it usually goes behind the the origin is around the left subclavian, and it's a common origin, I suppose, and then it goes behind the esophagus. The right subclavian goes retroesophageal, and then it ascends up. That's why you don't get that nerve hooking. So you should also look for the retroesophageal origin of the right subclavian artery.
In that case, CD thorax also becomes important.
CD thorax is also important. Anomaly. Yeah, you should have that look at actually before. Thank you.
For a small nodule, small thyroid cancer, you don't require CT scan. So if lot of nodes are there and tumor is quite big, and if you are doing CT neck and chest, in those cases you can see whether any abnormality of vessels are there or not. But just for purpose of ruling out whether this patient will have recurrent, non-recurrent laryngeal nerve is not or there or not, to have a CT scan, that will be too much for that one. For just 0.5, yeah. So that if indications for CT scan is there, in those patients you can see the all great vessels in the chest, but otherwise you don't have to, don't require to do CT scan just for purpose of seeing.
Nice presentation. There is a lot of learning. Thanks a lot.
Thank you.
Sir, Please wait on the stage only. Sir, please wait on the stage. I will request Dr. Kunal Kishore sir, Professor Radiation Oncology, to please come up on the stage and felicitate our chairpersons.
Thank you, sir. Thank you, sir. It was a wonderful session. So we are going to our session 2.
मैं निवेदन करना चाहूँगी डॉक्टर अरुणव कुमार सर, सीनियर रेसिडेंट न्यूक्लियर मेडिसिन IGIMS पटना से, कि वो स्टेज पर आए और moving toward our next session, first of all, I will request our chairpersons to join on the stage. Dr. Vibhuti Bhushan sir, Professor General Surgery, IGIMS Patna. Dr. Umakant Prasad sir, Additional Professor Radio Diagnosis, IGIMS Patna. Dr.
Dinesh Kumar Sinha, Additional Professor in Department of Radiation Oncology, State Cancer Institute, IGIMS. And Dr. Ravishwar Narayan, Senior Consultant at Nuclear Medicine, Medanta Hospital. Please come on a stage and have a seat.
Sir, please a few words for our speaker, Dr. Arunav sir.
Good morning all, and this is a very important topic, and this topic is on thyroid imaging, imaging of thyroid disease, of course benign and malignant both, and this is presented by one and only Dr. Arunav, who is just leading the Department of Nuclear Medicine at SCI IGMS Patna, and I would like to tell you that he is a very important person for Radiation Oncology Department also, in all the planning and all the PET-CT review. Everything, I think we get so much help from Dr. Arnav, and Dr. Arnav has experience from, I think, AIMS New Delhi. So I request Dr. Arnav to just showcase his knowledge. Thank you.
Thank you, sir, for kind introduction. Good morning, everyone. In next 30 minutes, we will be viewing the landscape of imaging in thyroid, starting from the conventional imaging, and at last we will see the some molecular imaging also, which is helpful in thyroid cancer. ये करना है और ओके स्लाइड वहाँ डेस्कटॉप पे है ना ये है ना imaging for the thyroid diseases. I will be focusing mainly on the thyroid carcinoma, as the conference is organized for the thyroid carcinoma update. So the types of imaging we see in thyroid, we have radiological imaging starting from ultrasound and cross-sectional imaging, CT scan and MRI. For nuclear medicine, we have isotope-based imaging, that is radioiodine. Commonly in India, we do iodine 131 level scan, as iodine 123 is not available in India. And normally the thyroid scan, which we see in our requisition slip, that is 99 mm technetium per techneted scan, and PET scan. So in the clinical setting, where we see the thyroid imaging, the most common situations are evaluation of a thyroid nodule, thyrotoxicosis, thyroid malignancy, and by the help of the ultrasound, we also aid in the diagnostic aspiration, biopsy, and few treatments. And less common situations are the congenital thyroid anomaly, ectopic thyroid detection, like sublingual thyroid or thyroglossal cyst, or even in the in utero investigation of fetal thyroid. In this talk, we will be focusing mainly on the evaluation of the thyroid nodule and progressing further towards the thyroid malignancies. Usually, the patient present with a thyroid swelling or thyroid nodule, any thyroid nodule should be further investigated. So radiologically, solitary thyroid nodule is a nodule which is a discrete lesion in a thyroid gland and which is radiologically distinct from the rest of the thyroid parenchyma. And while doing other imaging modalities like CT scan is done for different other indication or MRI is done for different indication, and you find out any nodule in a thyroid, that is termed as incidentaloma. This confers a thing that in any thyroid nodule, it confers any malignancy can occur in 7 to 15% cases depending upon the risk factor. So thyroid nodule should be evaluated further. In the evaluation of thyroid nodule, clinical evaluation and previous histories plays a major role. Few live investigations are there and radiological findings, which is further shifted to next is cytology and management. So in case of if we found out any thyroid nodule, the first investigation is to do thyroid profile to see the TSH. If the patient is hyperthyroid, that is TSH is subnormal, then we have to do thyroid scan, that is technetium 99mm per technetium scan, to see whether that nodule is hyperfunctioning or gland itself is hyperfunctioning. So this is the thyroid scan. It can be done either with iodine 123, which is not available in India, so we commonly means thyroid scan is 99mm technetium per technetium scan. So you can see the uptake, that is the white area, uptake in the normal thyroid gland. This is the lower thyroid gland, but here is the photopenic area, there is no uptake. So this is the cold nodule. Here is the one nodule is not appreciated, and it is taking uptake as equal to the rest of the thyroid gland. But clinically, we have to put a marker on a nodule to assess where is the nodule and how much uptake is there. And this is the hot nodule. Rest of the thyroid gland uptake is suppressed and only nodule is taking the uptake. So concern for the malignancy has got the cold nodule. As 16 to 20% cases, the cold nodule will become a malignant. So in preoperative assessment, is there any role of thyroglobulin or calcitonin? So ATA guidelines recommend there is no 2 or 4 recommendation for the thyroglobulin or calcitonin assessment. But if thyroglobulin done in any case and it is higher on the very higher side, then we can assess the disease burden by this thyroglobulin test. Coming to the ultrasound neck should be performed in all patients who have suspected thyroid nodule or thyroid goiter or incidentaloma. In ultrasound, we have to look for the size and location of the thyroid gland, and there are the few features based on which by this non-invasive, easily available technique ultrasound, you have got your suspicion index whether this nodule is malignant or benign or anything else. So we have to look upon the features like composition, echogenicity, shape, margin, and echogenic foci and vascularity. We will see the images further. This is the sonographic suspicion index given by the ATA. When you see there is a solid hypoechoic nodule with additional features like microcalcification, taller than wider, you have got suspicion index of more than 70 to 90% that this nodule will be malignant, and FNA is recommended if more than 1 centimeter. Similarly, based on these features, you have different suspicion index like intermediate suspicion, low suspicion, and up to benign, where no biopsy or no FNA, nothing is recommended. So coming to the composition, you see in the first image, it is entirely cystic nodule. Here you can see the tiny cystic components are covering more than 50% of the gland, so this is a spongiform pattern. These two usually defines the benignity of the thyroid nodule. Here you can see the mixed solid and cystic lesion. This is the solid component, this is cystic component, and here is the solid lesion. So if you find any such lesion, as said earlier, you have got high suspicion that it could be a malignant nodule. So another component is look at the echogenicity. Again, this was cystic, and this is based on echogenicity, this is anechoic. Then you have got this hyperechoic. By comparing with the normal thyroid parenchyma, this is hyper. So hyperechoic, normal thyroid parenchyma, it is isoechoic. In comparison to the normal thyroid parenchyma, it is hypoechoic. Echogenicity is low, and this is very hypoechoic. So these two had got the greater suspicion index, whether this is very hypoechoic or hypoechoic. Very hypoechoic is in relation with the strap muscles. Coming to the shape, this determines the benignity of the lesion, that is normal, wider than the taller. But if you find out any lesion taller than the wider, the anteroposterior diameter is much more than the transverse diameter. It has got 3 points on the thyroid, so it is the defining factor for malignancy. Coming to the margin could be well-defined margin or few area of ill-defined margin. Here you can see the irregularity of the margin. The margin could be lobulated appearance, or there could be the extrathyroidal extension. You see the lesion is extending beyond the normal thyroid gland. So these sorts of the finding signify towards the malignancy. And inside the gland, we have to look for any echogenic foci. Like here, you can see the comet tail artifact. It determines towards the benignity of the lesion. You can find a coarse calcification, you can find a peripheral calcification, or you can find multiple punctate calcification.
This has got high suspicion index, multiple punctate calcification. So based on this, American College of Radiology has given the thyroids. You assign the different points for the different components as we have discussed now, composition, echogenicity, shape and everything. Based on that point, if the point is more than 7, that is thyroids 5, and we have to do FNA if the lesion is more than 1 centimeter. And if it is 4 to 6, thyroids 4, and the size is more than 1.5 centimeter, do FNA. And if it is 3 point, that is thyroids 3, and the size is more than 2.5 centimeter, do FNA. The only difference from the thyroids and ATA guidelines is that ATA guidelines has slightly lower size criteria for putting a needle. Otherwise, the both has got the similar features. So this one is the ATA. You see where FNA is recommended. Nodule is more than 1 centimeter with both high and intermediate sonographic suspicion. And in the low suspicion, ACR recommends 2 centimeter. It's 1.5 centimeter. So and after FNAC, sometimes the path report will come as non-diagnostic, non-contributory. So that means that the adequacy of the sample, they find at least 6 group of follicular cells should be present in each group, and in each cell, each follicle, there should be 10 cells preferably. This will be important in this slide. This is the Bethesda updated in 2023. So after radiologists do ultrasound and give FNAC sample, the FNAC report will come out as either non-diagnostic, benign, AUS, follicular neoplasm, suspicion of neoplasm or malignant. And this is the risk of malignancy. You see in non-diagnostic, the risk of malignancy is 13%. So you go back again, do ultrasound guided, repeat FNA, so that you can find out whether this lesion is malignant or benign to recharacterize the lesion. And when it is given as a suspicious for malignancy, it is 74 chance of risk of malignancy, and when it is given malignant on Bethesda, 97% chance it will be malignant. So coming to the role of, is there any role of FDG PET-CT when you find out any thyroid nodule? So FDG PET-CT is not recommended for evaluation of patient with newly detected any thyroid nodule. But however, if PET-CT is done for any other malignancies for a staging workup and you detect a nodule, then if nodule size is more than 1 centimeter and it is taking FDG uptake, do ultrasound examination and FNAC of the nodule, as 35% of the cases could be malignant. This was a meta-analysis. See the number of the patients they did in a 15,000 patient, in which focal thyroid incidental uptake on FDG PET-CT were evaluated on ultrasound and FNAC, and pool malignancy risk was around 35%. This was another systematic review in which 55,000 were evaluated, and they also found the chances of malignancy is 33% if you found a focal uptake on FDG, and PTC was, papillary thyroid carcinoma, was more prevalent among them. So this was the lymphoma patient. This nodal uptake level 4 is of lymphoma, lymphomatous involvement of the node. But you see here in a thyroid there is a focal hypodense lesion, and this is showing the focal FDG uptake. On ultrasound characteristic, as we discussed now, this is the solid hypoechoic lesion, multiple foci of calcification is in irregular margin. So you have got high suspicion that it could be malignant, and increased vascularity, you put a needle and they found it as a papillary thyroid carcinoma. So coming to the histology, from the origin of the cell, it could be follicular cell origin or parafollicular cell origin. In follicular cell origin, there is the two extremes. One is differentiated thyroid cancer, another is anaplastic thyroid carcinoma. In between, there is poorly differentiated. And from the parafollicular C cell, here comes the medullary thyroid carcinoma. So all the thyroid cancer do not concentrate the iodine. So all thyroid cancer are not radioiodine avid. So usually those thyroid carcinoma which are differentiated concentrate the iodine. Frequently, there are the mixed data whether the tall cell columnar cell subtypes, previously called variant, oncocytic carcinoma and poorly differentiated carcinoma may or may not concentrate the iodine, and almost never concentrate iodine are anaplastic and medullary. So as we discussed, usually the thyroid carcinoma patient usually present with asymptomatic nodule or incidentaloma, or they may present with the lymph nodal metastasis or local invasive feature like aerodigestive tract involvement, nerve involvement, hoarseness of voice like that, or sometimes we direct present with the metastatic features. So in diagnosis, preoperative staging, as we see, ultrasound alone has got high sensitivity and specificity for detecting thyroid malignancy. Neck imaging, cross-sectional imaging, CT scan, MRI, PET sometimes, as we will discuss further, can be useful, and measurement of serum TG and anti-TG antibody. So neck imaging, we discussed about the thyroid nodule, and now coming to the lymph nodal. In DTC, cervical lymph node metastasis occur in 20 to 50% of the cases, but in 90% cases there will be the micrometastasis, less than 2%. So preoperative ultrasound identifies the cervical lymph node metastasis in 20 to 31% cases, but this is very useful as you can change the plan of management, determining early change in the lymph nodal. So ultrasound feature of metastatic lymph node is the most sensitive feature is the loss of fatty hilum, size is enlarged obviously, and if you find any microcalcification within the lymph node, it has got high specificity. So any lymph node which has got loss of fatty hilum, enlarged in size, rounded, and microcalcification is seen inside it, there is a high suspicion that lymph nodal metastasis has occurred based on ultrasound. The search pattern during ultrasound is the location of the lymph node as discussed in the surgical anatomy previous lecture. The pattern is central compartment to the lateral compartment. But sometimes when there is the upper pole thyroidal involvement, it can give direct skip metastasis to the level 2 and level 3 nodes. So recommendation is the preoperative neck ultrasound for the cervical lymph nodal staging is recommended, and if any suspicious node is there which could change the management, which is more than 8 to 10 mm, then FNAC is recommended from that node. Coming to the neck imaging, as we have discussed earlier, the CT scan is recommended when on ultrasound you find bulky disease, much more of the nodal disease is there. So there is a chance it could be in the mediastinum, infraclavicular, retrophageal location. So preoperative imaging with CT scan will be helpful in these cases. The sensitivity of MRI and PET for detecting cervical lymph nodes are very low. So sometimes DTC can present as present with the invasive features like involvement of the aerodigestive tract and neurovascular bundle. In these settings, the cross-sectional imaging will be helpful for the preoperative planning to accurate delineation of these structures. As this was one case where solid hypoechoic lesion with calcific foci are seen within, and it was the gross disease, gross disease. So CT scan was done with contrast CT scan is done, and here we can see there is the nominal non-filling of the contrast in the left IGV, left internal jugular vein, and the color flow also doesn't take. So it means that there is the tumoral involvement of the left internal jugular vein, and there is the also lymph nodal metastasis extending into the in the upper mediastinum, and few lung nodules are also there. So in such cases, CT will be helpful in the proper staging of the patient in preoperative settings. And there is the discussion like in post-op setting the patient may require the radioiodine therapy, so whether to give contrast or not, or hold up the contrast. So if that contrast will change the preoperative management and it will be helpful in the delineation, then it is better to give the contrast because it outweighs any potential risk that is waiting of the several week delay in radioiodine imaging therapy. And if is there any concern of radioiodine contamination, you can do iodine to creatinine ratio or urinary iodine excretion that is less than 100 microgram per 24 hour. If you suspect any brain metastasis, you can go for the brain MRI. So recommendation with the CT and MRI with IV contrast is recommended by ATA, and routine preoperative FDG PET scanning even in suspected or diagnosed case of thyroid cancer is not recommended by ATA. This is a strong recommendation. And preoperative evaluation with serum TG and ATG is also not recommended in pre-op stage. Coming to the, now we have made the diagnosis, surgeon will do the operation, and coming to the role of imaging in post-operative setting. We are talking in the differentiated thyroid carcinoma. So in post-op setting, we have three things: serum thyroglobulin level, neck ultrasound, and iodine 131 whole body scan. This iodine 131 whole body scan is not the normal thyroid scan we prescribe. Thyroid scan is 99 m technetium per technetium scan. This is iodine 131 whole body scan with or without spexity. So in post-operative neck ultrasound is done to look for any residual or remnant disease, and if there is no any residual or remnant disease and TG is very low, then the chances of recurrence is very less, which is shown in a prospective study done by Lee et al. So in post-operative setting, the role of iodine 131 whole body scan is to see the presence of any residual radioiodine event, local disease present or not, any metastatic disease which will alter the management, and it also helps in the guiding whether how much dose the patient will receive for the radioactive iodine treatment. So iodine 131 whole body scan in post-operative setting, the TSH should be more than 30, which can be achieved either by the withdrawing thyroxine or you can give RS-TSH stimulation, but it is very costly affair. And you have to give the dose of 2 to 3 millicurie of iodine 131, and scanning is done after usually 48 hours. Planar imaging is required, and whenever in doubt we will do spexity of that region. So if radioiodine therapy is done, we also acquire the post-therapy scan because to inform the disease staging and document the radioiodine ability and any structural disease present. So this was 17-year-old female who presented with PTC post-thyroidectomy. Whole body iodine scan was done by giving 2 millicurie of iodine and 48-hour imaging. This is the whole body head to toe imaging. This is the physiological uptake of the stomach and bowel. And this is the bladder activity denoting the genitourinary route of excretion. There is the focal uptake in the neck, which is confirmed on SPECT and ultrasound. There is the remnant. Remnant is the normal thyroid that is left in a thyroid bed after surgery. So this is another case, 20-year-old with follicular variant of PCT. The two focal uptake are seen in the neck, which on further SPECT and neck ultrasound, one is the remnant and another is a paratracheal node. So even all the sorts of metastasis in differentiated thyroid carcinoma, which are radioiodine avid, this is the very specific theranostic agents for the thyroid carcinoma. See the brain, the patient was present after 5 years on follow-up, the patient presented with the dizziness and headache. Radioiodine scan was done, whole body iodine scan was done, and it is for the brain metastasis. This was another case where the site of skeletal metastasis, sternum, scapula, and lumbar vertebra. This was another case showing the bony metastasis. And this was the case where it shows the diffuse lung uptake. Usually the iodine shouldn't go in the lung. If it is going diffusely, it could denote the micrometastasis. Even micrometastasis in lung sometimes may be missed on the CT also. So radioiodine 131 whole body scan plays a vital role in staging, and we found a focal uptake in the axillary region, which is quite uncommon. So we did the SPECT CT, and we find out that there is axillary node which is taking radioiodine, and it was proven on FNA it was the metastasis from the thyroid carcinoma. So that was in the post-op setting. Now the patient role of imaging during follow-up of the patient. So during follow-up after surgery, and cervical neck ultrasound is done in 6 to 12 month interval, and if after first radioiodine post treatment scan following the remnant ablation, if the iodine whole body scan is negative, then no need to do further radioiodine scan in next follow up after 6 months. Just do follow up with thyroglobulin and ultrasound. If there is persistent disease, keep on doing and treating with radioiodine up to tolerable dose. So after some time of the treatment, you will find out the malignancy has become radioiodine refractory. It has got 4 definitions. It could be the malignant lesion or metastatic disease that do not concentrate the iodine from initial scan, or during the course of the treatment. During the course of the treatment, some lesions are taking, but some lesions are not taking iodine, or despite of taking radioiodine, it is not responding to the radioiodine. Then these all cases are the radioiodine refractory. So in this setting, you are following up with a thyroglobulin. You are now seeing the thyroglobulin is elevated, but iodine whole body scan is negative. That is termed as a tennis. Thyroglobulin elevated, negative on iodine scan. So this is the indication in differentiated thyroid carcinoma where FDG PET CT is prescribed. So FDG PET is done for this evaluation of the tennis and localizing the TG producing lesions. So this was the case on post-op setting. The thyroglobulin was elevated up to 27 gradually on follow-up, but there was no detectable disease in the neck or elsewhere in the body on iodine 131 whole body scan. So FDG PET was prescribed, and FDG PET shows there is the recurrent disease in the right thyroidal bed with the lymph nodal metastasis as shown in the images. So this is important. So value of the FDG PET CT in DTC has effectively shown in various studies as shown in this studies by the Dong et al, which shows the 94% of the pool sensitivity for evaluation of recurrence and metastasis. So this was the differentiated thyroid carcinoma. Another spectrum is the medullary thyroid carcinoma, which arises from this parafollicular cell, and usually there are 2 forms, sporadic and hereditary forms, 75 and 25% respectively, with red proton concentration. There are various secretory products, but two products that are important to us as a tumor marker is calcitonin and CA. Whenever the medullary thyroid carcinoma is well differentiated, it will produce calcitonin only. But when it start to lose its differentiation, the CA will take charge upon the calcitonin. This will play a role in the imaging. The guideline updated was in 2015, but NCCN is updated in May 2023. So we will be looking upon both. In preoperative evaluation, again ultrasound and FNAC has played vital role in the medullary thyroid carcinoma with calcitonin washout levels in FNA samples. In preoperative imaging, if initially serum calcitonin level is more than 500 picogram per ml, then there is the role of cross-sectional imaging and the nuclear medicine imaging to search for the site of metastasis because the calcitonin burden is more than 500. So ATA doesn't recommend FDG or FDOPA. It was in 2015 updated, but recently NCCN has updated that the gallium-68 DOTA-TET PET-CT, which is done for the SSTR expression neuroendocrine tumor, as parafollicular cell origin from the ultimobranchial body neural crest. So SSTR expression is there, and gallium-68 DOTA-NOC PET-CT should be done at initial staging workup. But in post-op setting, whenever there is the calcitonin level is more than 150 picogram per ml, then cross-sectional imaging with DOTA-NOC or FDG PET-CT can be done. So one study was done to evaluate the role of gallium DOTA-NOC and FDG PET-CT with correlation with the biomarker, that is calcitonin and CA, and they found out that the individual with higher calcitonin level, where the lesion were much detected by the DOTA-NOC PET-CT, and where there is a greater CEA value, the lesion was detected much more by the FDG PET-CT. So this was the gallium-68 DOTA-NOC PET-CT. In FDG PET, we will see the brain uptake, but here there is no physiological uptake in the brain, only pituitary uptake is there, and you will see the intense uptake in the spleen and the liver. By this way, you will identify the gallium-68 DOTA-NOC PET, discriminating from the FDG PET. You will see how beautifully it has shown all the site of skeletal metastasis, mediastinal involvement, nodal disease, bone metastasis, and everything. So this is the modality of choice. And also it has got the theranostic value. If you replace this gallium-68 with the lutetium-177, you can treat the metastatic medullary carcinoma thyroid which are not responding to the conventional treatment. And coming to the extreme modality, that is the anaplastic thyroid carcinoma, which has got highest mortality risk as discussed earlier. 1 year survival is less than 20% and median survival is only 5 months. So it is very aggressive and low iodine avid. The ATA guideline updated in 2021, they suggest that the directly FDG PET-CT should be done, and it should be done expeditiously. So there shouldn't be any delay in imaging by telling there is a long waiting list or something else in the department.
Meeting join हो गया
है. If accessible, FDG PET-CT is particularly valuable in evaluating metastatic sites that are sometimes not appreciated at cross-section level. If not available, go for the CT scan. And even during follow-up, if there is no disease burden left, then also do FDG PET-CT to see whether there is any small amount of the clinical relevant disease present or not, or even for the response assessment, you can do FDG PET-CT. This was the case of anaplastic thyroid carcinoma showing FDG avidity in the neck bed, sternal metastasis and the mediastinal node metastasis. FDG PET-CT was done. These all studies are again showing the role of SUV max. You can also prognosticate the patient. This one, above one is the one patient, another one is the different ATC, but both are the ATC patient. You see the intensity of the uptake. This patient survive for only 2 months. And if the uptake is low in the anaplastic thyroid carcinoma, this patient survive for the 8 months. So you can also prognosticate the patient based on the uptake. In between, there is the term poorly differentiated thyroid carcinoma. What happens is when thyroid carcinoma is well differentiated, sodium iodide importer is there. When it loses its differentiation, the sodium iodide importer will become less and GLUT receptor expression will be more. Based on this hypothesis, FDG PET-CTs are being done in poorly differentiated thyroid carcinoma and has got good sensitivity of around 80 to 90%. This was again case of poorly differentiated thyroid carcinoma showing uptake in a thyroid bed and mediastinal nodes. Other aggressive variant studies are being done like tall cell variant, solid insular variant of whether FDG PET-CT can be done for staging and re-staging. This image is showing flip-flop phenomenon, like at one end there is differentiated thyroid carcinoma, another is anaplastic. So I discussed earlier the iodine uptake is much more in the DTC, whereas when the spectrum goes toward the anaplastic, the FDG uptake will show. So this, by remembering this site, we can prescribe when to prescribe whole body scan, when to prescribe FDG PET-CT scan. You can see the lesion is quite heavy on the iodine scan, but there is no lesion on this FDG PET-CT. Again, another image. The radioiodine scan is negative, but FDG PET-CT is showing the multiple lesions. So this is the flip-flop phenomenon. Coming to the recent advances, I am talking on only imaging, so focusing on the on theranostic pairs. As we see, the differentiated thyroid carcinoma has got very good survival. More than 97%, 10-year survival is got for DTC. But the radioiodine refractory DTC, 10-year survival is only 10%. Poorly differentiated thyroid carcinoma survival is even poor. ATC, only 1 year survival is 20%. So research focus on whether we can opt for any newer treatment option for improvement of overall survival. Previously, theranostic pairs has been tried like iodine 131 MIBG, DOTA-NOC, which is replaced by the lutetium 177. Now recent and RJD peptide. Recently on AIIMS New Delhi, we were doing with a Gallium-68 FAPI imaging. FAPI is a target fibroblast activated protein inhibitor. It will target the tumor microenvironment, so detection rate is high and you can even treat the patient. We will also end up in last 2 slides. In this study was done in a PGI Chandigarh. They showed in a radioiodine refractory tennis papillary carcinoma with tennis. They tried imaging with a gallium-68 DOTA RGD, which is and again the gallium is replaced by the lutetium-177, and they treat the patient. This is the diagnostic imaging with gallium-68 DOTA RGD. They show the external skeletal metastasis and mediastinal nodes and bone metastasis with a lung metastasis. They give, this is the post-therapy scan given with lutetium-177 DOTA RGD aspect, and this was the post-therapy scan. This scan shows there is the avid concentration of the lutetium-177 in the sites where there was the uptake as shown in the gallium-68. So this is the precision oncology, where whatever you are seeing, you are delivering dose to the same place. And this is the post-therapy on follow-up scan post-month after. The disease is quite stable, or there is a minimal decrease in FDG uptake, but disease hasn't progressed further. Coming to the recent advances, that is the DOTA FAPI, which is being done at AIIMS New Delhi. This is the paper from the AIIMS New Delhi. The DOTA FAPI, gallium DOTA FAPI has in radioiodine refractory thyroid carcinoma, as I discussed earlier at FDG PET-CT, DOTA FAPI has got much more sensitivity and lesion detection rate than FDG PET-CT. As you can see in this image, the left hand side image is FDG PET-CT of the same patient, where you can see the fewer lesion in the in the lung and the nodes, but you can see here the much more lesion are detected, and the bulky mediastinal disease and the lung metastasis and the liver metastasis which are evident on the DOTA FAPI. And even DOTA FAPI can be used as a treatment. You can see those patients which are radioiodine refractory and exhausted all saw a standard line of treatment. The TG baseline level was 3000. Post treatment with lutetium FAPI, the TG was 280, and there was the partial response and the stable disease. And none of these patients experience any hematological, renal or hepatotoxicity. So to summarize, for any STN, characterize the nodule, assign the thyroids. Cross-sectional imaging may be helpful in preoperative staging and delineation of surgery. In post-op setting of DTC, iodine whole body scan for staging and assess the radioiodine therapy. In follow-up setting, ultrasound and TG and anti-TG once radioiodine whole body scan is negative. No need to do further. FDG PET-CT again is not recommended in initial evaluation of DTC, only useful in cases of the tennis, few selected cases of high-risk patient of aggressive histology, PDTC. In MTC, if calcitonin is raised, go for DOTANOC PET-CT. If CEA is much more rising, go for FDG PET-CT. Anaplastic directly if available, go for 18F FDG PET-CT. And now the research is focused on, as discussed, on newer theranostic options, improvement in overall survival for radioiodine refractory DTC, PDTC and ADTC. The acknowledgement, Department of Nuclear Medicine, AIIMS New Delhi. References are from the ATA guidelines and NCCN thyroid cancer update. This is Saul, father of nuclear medicine. He has given the first radioiodine treatment in human in early 1940s. So for the last 80 years, theranostics has been there in a thyroid cancer. Thank you all.
Knowledge with us. It was really a commendable talk that you delivered. I would request our chairpersons to conclude the session, and question answer session is also on the way.
Very nice topics like radiology, nuclear medicine, treatment, all part is covered in one lecture. To take home message is that if the lesion is cystic, there is no need of FNAC. Purely cystic lesion or spongy lesion. Usually OPD, many patients come with a cystic lesion for FNAC. So we should avoid that by simple USG screening at OPD or other center. And if the lesion is more heterogeneous or irregular margin or height more than width, or there are punctate calcification, then we go for FNAC or biopsy or other imaging modality like whole body scanning. Thank you.
One case I encountered recently in OPD, the patient came with hemithyroidectomy, and I just advised her for whole body iodine scan, but her TSH was not at present. I think we are not doing the whole body iodine scan at SCI, so we just referred the case to outside, and Dr. Parasar has just told that, and the patient was also very and not understanding why the physician is advised and he is not doing the scan. So the TSH was not increasing. In that case, he advised for total thyroidectomy. just talked to Dr. Manish that in this case total thyroidectomy is needed, so he's agreed on. So what is your take, and Dr. Rajiv Saran can just point it out on this case.
Sir, the
patient came with hemithyroidectomy and iodine scan, whole body iodine scan was not being done because TSH was not increasing even after just human thyroxine.
Yes, sir.
Dr. Aruna,
Blood invasion, vascular invasion, anything that will prompt you for go for a total thyroidectomy or ablate that remnant thyroid lobe. So the thing is, the patient has been sent for the iodine 131 whole body scan. The thing is, the left lobe or the right lobe, one lobe is already present there. That lobe is already producing T3, T4, and by the negative feedback mechanism, it is suppressing TSH. So that one lobe is also acting as a functional thyroid only. So in that scenario, the TSH won't come to the more than 30 level because already functioning thyroid is there. So the thing, if you really want to do for that setting, you can raise that TSH level iatrogenically. That is by RS-TSH. That is around 30. That will cost you around 80,000. But that is of no need, because that patient will, if you have got high risk, that patient will directly go for either completion thyroidectomy or you can do direct lobar ablation. Recently, we have published a trial from AIIMS New Delhi, which shows lobar ablation versus surgical completion thyroidectomy. In overall survival or any risk benefit, it has come out to be non-inferior to the completion thyroidectomy. So, because revision surgery is quite difficult in sometimes, and if you want to do that, go for a lobar ablation with 40 millicurie of radioiodine. Now the thyroid is ablated. Now you will stop the thyronome, then TSH will rise, go for the staging iodine 131 whole body scan, stage the patient and treat further. So by the lower ablation with 40 millicurie, you can sort out this issue without even going for the completion thyroidectomy.
So if hemithyroidectomy has been done, so in that case there is no role of radioiodine scan. So better to just review the slides and block and then see what all poor prognostic factors are there to determine whether patient requires completion thyroidectomy or not. So if no poor prognostic factors are there, in that case patient can be followed up with just hemithyroidectomy. Like if lesion size is less than 1 centimeter or less than 4 centimeter with no other poor prognostic factors like LVI, lymphatic invasion, vascular invasion, or margin resection margin is negative. So in those cases, you can just do follow up in those with just only hemithyroidectomy. But if margin is positive or vascular invasion is there, in those cases, patient requires completion thyroidectomy. So radioiodine scan is done only when total thyroidectomy has been done to see all metastatic sites anywhere else is there or not.
Correct.
So with hemithyroid is intact, so all your iodine that will go in the thyroid only. So you will not get any information in those cases.
Congratulations, Dr. Arnav. Very excellent presentation. And he has done the impossible task of trying to cover gamut of nuclear medicine use in thyroid diseases. One thing he has intentionally left is when the radioiodine, when the DTC becomes refractory to radioiodine, then all hope is not always lost. We can try de-differentiation therapy. We give retinoic acid and other medicines. Yeah, and then we convert it again to radioiodine avid disease, and then again give high dose therapy, because so far
the best treatment is
radioiodine therapy. Thank you.
Regarding the usage of FNAC in thyroid, often periphery when patient comes, he already underwent one FNAC procedure. But we have a definite indication of FNAC in thyroid nodule. First investigation usually we do is ultrasound. We have a thyroid score, and then that qualifies a patient who merits FNAC or not. Not that every thyroid lesion deserves FNAC. Okay, and thyroid is never, I mean, if the thyroid score is very low, then no need to do FNAC.
Thank you, sir.
And over to the, Dr. Vinita,
So I congratulate Dr. Arnav for your very nice presentation. But regarding lot of, I think around 8 to 10 days back, we saw one case in the tumor board that was a papillary CA thyroid, and he was just 12 to 13 years old. This is a rare situation. So, if I'll ask Dr. Rajiv Sharan also regarding this, what precaution, pediatric surgery, how does it differ from adult surgery? And if patient requires radioactive iodine ablations, then what precaution we should take? So, do you have anything to comment on?
Usually pediatric DTC, which we had seen at AIIMS usually adult DTC, which we give is the empirical dose for the remnant ablation like 30 millicurie, for the metastasis 150 to 200 millicurie, and nodal mets like 50 to 100 millicurie. But in case of the pediatric DTC, where the radiation dose burden would be high, you can't give such empirical therapy in pediatric DTC. So you have to give around dosing is around 2.15 millicurie per kg body weight of the pediatric DTC, or depending upon the disease burden of that DTC. And in pediatric DTC, it is much more common to have if there is a thyroid lesion, it is much more common to have a neck metastasis. If thyroid lesion plus neck metastasis, nodal metastasis there, it is much more common to have a lung metastasis in cases of the pediatric DTC. And if available in higher centers, you can also go for the BRAF mutation, whether present or not, to see as this child has to live longer than adult patient, so you can do this all also, but surgical aspects are
Because he presented with a small neck node, and then after evaluation it was found that he was having a small thyroid nodule also, which came out to as papillary carcinoma thyroid.
So there was the neck node, thyroid lesion with nodal disease. Go for a screening HRCT chest also to see for any diffuse or lung mets is there or not.
One thing I would like to add, ma'am. The thing is, just because it's a pediatric population doesn't mean we can't give radioiodine. ATA clearly says that for children greater than 5 years of age, the future risk of malignancy because of radioiodine therapy is equivalent to future risk of malignancy because of radioiodine in adults. So after 5 years of age, if DTC is diagnosed, we can go ahead with what he is saying, not empirical doses, but per kg wise pediatric doses.
So this is all like most of these patients will be very good in pediatric age group. And regarding surgery part, obviously, like if 7-year-old kid, if you are operating, your recurrent laryngeal nerve will be very thin, and your parathyroid size will be also small. So it's very difficult to identify the structure. So those who are having experience in thyroid surgery, they can operate. I have operated upon, I think, 7 years minimum age group. Came with extensive nodal mats. Bilateral neck nodes were there. Did total thyroid with central compartment with total bilateral neck dissection, and patient did well. Post.
Last common question, the patient has to isolate after whole body radioiodine or not?
Yes,
the layman question. After
iodine 131 whole body scan, we are giving 2 millicurie. Even up to the treatment, that is remnant ablation, up to 30 millicurie, you can do on a daycare patient basis, no need of admission is there. Because the discharge limit is 5 mR per hour from 1 meter distance from the thyroid bed. So if you have to discharge the patient, the 30 millicurie dose which is delivering to the patient, the dose emitted by the patient is less than 5 mR per hour. So you can discharge the patient for the diagnosis also. But the patient who are requiring high dose therapy, more than 30 millicurie, you have to got isolation bed, which is not available as of now in Bihar. Hopefully we'll get one soon.
So those like dose of radioiodine is always very, very controversial, and that depends upon which school of thought you follow, where you have been trained. So like if you are trained in All India Institute of Medical Sciences, then if after total thyroidectomy there is no uptake in a scan, then you don't give. Like, yes, no. But other centers, even if features of aggressive variant is there, and if disease was advanced, in those cases, even if that uptake is not there, you still go for adjuvant radioiodine treatment. This is like radiation therapy for a normal any cancer. So even if indications are there, margins are negative, but still you go for that for radiation. So similar thoughts are also there in thyroid cancer. So if extra thyroidal spread was there, multiple nodes were there, even with negative iodine scan, some still micropapillary cells can be there. So their hypothesis is to irradiate those cells, you give adjuvant radioiodine treatment in those patients. But like Dr. Bal from All India Institute, he says if you give radioiodine, that is going to your salivary gland, and that you will have xerostomia later on. So for few cells, you like patient doesn't require 100 millicurie of radioiodine.
I just want to ask you, for iodine scan, which one is more for diagnostic iodine scan, thyroid scan? I just want to whether we should use iodine 123 or 131 or a technetium 99 or MIBG scan, which is mostly used.
All of these tracer has got different properties. As pertechnetate scan is monovalent ion, which has got similar property as iodine, which is also monovalent. The only difference will be in the organification. If you give the iodine 131, it is acting as iodine only because it is isotope of iodine. It will go inside the thyroid, it will organified, act as iodine, so it could be stayed there for a longer time, used as a theranostic agent. But if you are doing with a pertechnetate, it is not iodine, but it is mimicking as iodine, being a monovalent ion. So it will go inside the thyroid and it will escape out from thyroid as easier because it is not being organified. And MIBG is basically for the noradrenaline analog, which is basically for the neuroendocrine malignancy, pheochromocytoma, medulloblastoma, medullary thyroid carcinoma, like that. And coming to that iodine 123 and iodine 131, iodine 123 as of now is not available in India, but for the diagnostic modality, if available, it is the best rather than iodine 131 because iodine 131 has also got the beta that you are giving that patient and exposing for much more radiation. If it is available, go for iodine 123. If not, in India, we are doing with iodine 131.
Thank you. Thank you.
Now I would like to request Dr. Sanjay Kumar Suman sir, HOD Radio Diagnosis, IGMS, please come on stage and felicitate our chairpersons. A big round of applause, please. Hello. दूसरे सत्र की समाप्ति के बढ़ रहे हैं। हमारे चेयरपर्सन्स हैं डॉक्टर नरेश कुमार, हेड ऑफ डिपार्टमेंट जनरल मेडिसिन IGIMS, प्लीज कम ऑन स्टेज एंड टेक अ सीट।
Dr. Sudhir Kumar sir, Professor General Medicine, IGIMS Patna, please come up on the stage.
Dr. Krishna Gopal, Professor in General Surgery Department, please come on stage and have a seat.
Dr. Mukesh Bharti sir, Assistant Professor and HOD, Radiation Oncology, DMCH, please come up the stage sir. May I now request our speaker, Dr. Ved Prakash sir, Additional Professor and HOD, Endocrinology Department, IGIMS Patna, to deliver his talk on medical management of thyroid disease.
Medical management of thyroid disease. We all know that thyroid disease has multiple aspects. It can present as hypothyroidism or hyperthyroidism also. Dr. Ved Prakash has done his DM in endocrinology from prestigious institute, Banaras University, Banaras. Dr. Ved Prakash.
So, good afternoon to everyone. First of all, I would like to thank Dr. Manish for this opportunity. And the topic given to me is management of non-malignant thyroid disorders. And as such, this topic is very vague. What is non-malignant? It can be hypothyroid, it can be hyperthyroid, or it can be evaluation of the thyroid nodule. So basically, I have made the presentation on the evaluation of thyroid nodule, but already most of that part was covered by the previous speaker. So I will try to speak on some functional status of the thyroid diseases like hypothyroid or hyperthyroid. I don't have slide, but I will try to speak. So basically, whenever a patient came with anterior midline neck swelling, then the two main aim of any doctor is to define, first is to define the functional status of the patient, that whether this patient is of hypothyroid or hypofunctioning, hyperthyroid or hyperfunctioning, or whether it is a functionally euthyroid. So, and the second, after defining the functional status of the patient, the next step is to define whether this is a benign disease or whether this is a malignant disease. So, we all know the epidemiology that the thyroid disease is a very common disease nowadays, and the prevalence of nodular goiter by clinical examination, like by palpation, the prevalence is only 5 to 7% worldwide, but in India it is around 12%. But in contrast to the clinical examination, when we do the high definition ultrasonography, the incidence of thyroid nodule increases to 50 to 70%, and at different autopsy series, it has been found that 50% of the population has some degree of thyroid nodularity in the autopsy. At the autopsy, and the incidence of nodularity basically depends on the age. The incidence of thyroid nodule is very less in less than 15 years of age. It is almost less than 1%. But at the age of 60 years, more than 60 years, the incidence increases up to more than 50%. And like all the thyroid disorders, the incidence is more common in the females in comparison to the male, and the ratio is almost 4:1. So, now coming to the differential diagnosis of the thyroid nodules, there are various conditions. It can be benign, it can be malignant. In benign, it can be due to colloid cyst or simple or hemorrhagic cyst. It can be due to thyroiditis. It can be follicular adenoma, colloid nodule or hyperplastic nodule. And if the patient is of hyperthyroidism, then it can be toxic adenoma, or it can be toxic multinodular goiter, or it can be, and if there is diffuse enlargement, then it can be Graves' disease. In malignancy, there are various types of malignancy like differentiated thyroid carcinomas, anaplastic carcinoma, lymphomas, etc. So now coming to the evaluation, first evaluation should be the clinical. And in clinical evaluation, the examination and history and examinations are important. In history, careful palpation of the neck should be done, and if patient can be asymptomatic, patient can have symptoms, local symptoms like swelling in the neck, pressure symptoms like dysphagia, hoarseness, and change in voice, and difficulty in breathing, difficulty in swallowing in cases of large goiter. And there are various clinical pointers which can indicate that the risk of malignancy is higher. Like if nodule is present in extremes of age, like less than 20 or 15 years of age, or more than 70 years of age, then chances of malignancy is more. If nodule is present in males, then chances of malignancy is high. If there is prior history of head and neck irradiation, history of rapid growth of a nodule, family history of thyroid carcinoma is there. If nodule is hard and non-tender and node is fixed to the either underlying or overlying structure, and if there is associated cervical lymphadenopathy is present, then chances of malignancies are high. But in most of the cases, this clinical history and examinations are insufficient to make the clear-cut diagnosis. So, the diagnostic evaluation after clinical examination, history and clinical examination, diagnostic evaluation, there are mainly 3 diagnostic evaluations should be done in cases of thyroid enlargement. First investigation should be serum TSH. Second investigation should be ultrasonography of the thyroid. And the third investigation should be fine needle aspiration biopsy or cytology. So the serum TSH should be the first investigation. There is no doubt. If any patient comes to you with goiter, then the first investigation should be the serum TSH. And serum TSH is basically done to know the functional status of the patient and to define whether the patient is, this is a case of hypofunctioning goiter or hyperfunctioning goiter or euthyroid goiter. So when we do the, first we do the serum TSH, then scenario comes that serum TSH is low, serum TSH is normal, or serum TSH is high. If serum TSH is high, then it is a case of hypothyroidism. If serum TSH is normal, then this most probably this is a case of euthyroid goiter. And when serum TSH is low, then it is a case of, then it could be a case of hyperfunctioning thyroid gland. So after TSH, we do the serum T3 and T4. And in T3 and T4, if serum T3 and T4, there are various permutation and combinations. If T3 and T4 are normal and TSH is low, then it is a case of subclinical hyperthyroidism. Means TSH is low, that indicates hyperthyroidism, but T3, T4 is normal, so that this is a case of subclinical hypothyroidism. Similar to the case in like subclinical hypothyroidism, where T3, T4 are normal and TSH is either TSH is slightly raised between 5 to 10 MIU per ml. So the first scenario is subclinical hyperthyroidism. Second scenario is TSH is already low, but T3, T4 comes out to be above the normal range. Then this is a case of overt hyperthyroidism. So subclinical hyperthyroidism and overt hyperthyroidism, these are the two diagnoses when TSH is low. So there are many controversies for that regarding the treatment of subclinical hyperthyroidism. Like similarly, that there are controversies whether to treat, whether to not treat in cases of subclinical hypothyroidism. Similarly, there is controversy in the treatment of subclinical hyperthyroidism also. There are various school of thoughts. Some are in favor of to treat subclinical hyperthyroidism. Some school of thought say that it is futile to treat subclinical hyperthyroidism. So what are the indications of treatment of subclinical hyperthyroidism? There are some indications, like if patient is more than 65 years of age and T3, T4 normal and TSH is low. So in elderly patients with subclinical hyperthyroidism, ideally it should be treated. Why it should be treated? Because in elderly people, even with subclinical hyperthyroidism, there is chances of development of various manifestations of thyroid hyperthyroidism. Like they are more prone for development of arrhythmias. They are more prone for development of the coronary artery disease, even in cases of subclinical hyperthyroidism. So in elderly people, even with subclinical hyperthyroidism, it should be treated. That is the first indication of treatment of subclinical hyperthyroidism is age more than 65 years. Now let us see the scenario where patient is less than 65 years of age. So in case of patients less than 65 years of age, there are some indications for the treatment of subclinical hyperthyroidism. And what are those indications? First, if any patient is suffering from the osteoporosis or the low BMD, or there is more chances of fracture, then it should be treated. Why it should be treated? Because the excess thyroid hormone, or even in the subclinical hyperthyroidism, has deleterious effect on the bone health. It causes bone loss, and that's why there is more chances of development of the fracture later on. So in less than 65 years of age, patients with low BMD or patients with osteoporosis, it should be treated. In less than 65 years of age, second, what are the other indications for treatment? The other indications are if any patient is suffering from the rheumatic heart disease or a structural cardiac heart disease. Patient is having mitral stenosis, patient is having left ventricular hypertrophy or any structural cardiac illness. In that case, there is more chances of development of different types of arrhythmia and other cardiac manifestations. So in that case, patient should be treated. So these are the some indications of treatment for subclinical hyperthyroidism in less than 65 years of age. Now, there is situation where the patient TSH is low and T3, T4 are high. So this is a case of overt hyperthyroidism, primary hyperthyroidism. Now, what are the causes of primary hyperthyroidism? So when any patient comes to you with primary hyperthyroidism, T3, T4 high and TSH is below normal, so first aim should be whether this is a case of thyrotoxicosis or whether this is a case of hyperthyroidism. Now question arises, what is thyrotoxicosis and what is hyperthyroidism? What is thyrotoxicosis? Thyrotoxicosis is basically simply any form of thyroid hormone excess is known as thyrotoxicosis. And hyperthyroid, what is hyperthyroidism? Thyroid hormone excess due to hyperfunctioning of the thyroid gland is known as the hyperthyroidism. So every hyperthyroidism case is a case of thyrotoxicosis, but not every thyrotoxicosis is a case of hyperthyroidism. So first, in case of overt hyperthyroidism, our first aim is to decide whether this is a case of hyperthyroidism or whether this is a case of thyrotoxicosis. So what are the causes of thyrotoxicosis? So what are the causes of thyroid? First is the hyperthyroidism. Second is the thyroiditis, subacute thyroiditis. So in subacute thyroiditis, there is destruction of the thyroid follicle occurs, and with the destruction of the thyroid follicle, whatever the thyroid hormone is stored in the thyroid gland, they are released into the circulation, and that causes temporary excess thyroid hormone in the circulation. And in that case, when you investigate, T3, T4 are high and TSH is low. But this thyroid hormone excess is a temporary condition, and most of the cases usually resolve spontaneously in 2 to 3 months of time or within 6 months of time. So in that case, the aim to differentiate between thyrotoxicosis and hyperthyroidism is that whether you have to treat hyperthyroidism or not to treat. So if this is a case of thyrotoxicosis due to thyroiditis, then there is no indication of anti-thyroid drugs or other definitive treatment like radioiodine or surgery. And that condition is self-limiting, and in subacute thyroiditis, there are various phases of presentation. In subacute thyroiditis, the first phase is the phase of thyrotoxicosis, and whether in that phase the clinical sign and symptoms of hyperthyroidism are present, and most of the patients have some neck discomfort, neck pain, difficulty in swallowing, difficulty in deglutition, and the neck pain can be so severe that it can disturb the patient day-to-day life. So in case of subacute thyroiditis, the first phase is the phase of thyrotoxicosis, and after 6 to 8 weeks, this thyrotoxic phase usually passes, and patient can convert into the euthyroid. And in most of the cases, this thyrotoxicosis, after thyrotoxic phase, patients become euthyroid, normal thyroid function. But in some cases, this euthyroid phase passes and patient may go into a phase of either temporary hypothyroidism or permanent hypothyroidism. So in that case, we have to evaluate later on after every 6 to 8 weeks to see whether the patient remains euthyroid or it is a temporary hypothyroid or permanent hypothyroidism. If patient develops permanent hypothyroidism, then we have to start levothyroxine replacement according to the patient body weights and according to the clinical situation, and we have to monitor levothyroxine therapy by the serum TSH level. So this is the first scenario, whether this patient is suffering from the subacute thyroiditis or thyrotoxicosis. The second case is this thyrotoxicosis is due to hyperthyroidism, that is hyperfunctioning of the thyroid gland. And in hyperfunctioning of the thyroid gland, what are the causes? The commonest causes in most of the 80 to 90% of the cases of hyperthyroidism is due to Graves' disease. Graves' disease is basically diffuse enlargement of the thyroid gland with hyperfunctioning status. The second cause is toxic adenoma, autonomously functioning single nodule. And the third cause is the toxic multinodular goiter. Multinodular goiter is present with some autonomous in some of the nodules, and that can result into the toxic multinodular goiter. So, after difference the treatment of this hyperthyroidism can be either antithyroid drugs or radioiodine therapy or the surgery. In toxic adenoma, where there is single adenoma is present and that is autonomously functioning, after initial treatment, after initial controlling of the thyroid status with the antithyroid drugs, the treatment of choice is the radioiodine therapy. In case of toxic multinodular goiter, the initial treatment should be the antithyroid drugs to control the hyperfunction status, and when patient becomes euthyroid, then you can go with the radioiodine therapy or you can go with the surgery. When the goiter is large, very large, causing compressive symptoms, when there is symptoms present due to large goiter, then in that case surgery is the treatment of choice. And when there is no compressive symptoms or there is no discomfort due to the goiter, in that case of toxic multinodular goiter, we can go with the radioiodine therapy. But the problem with radioiodine therapy in cases of toxic multinodular goiter is that there are different nodules with a different functional status. So some of the nodule can be destroyed with the radioiodine, some of the nodule cannot be could not be destroyed by the radioiodine. So in that case we have to monitor after giving radioiodine that the functional status became euthyroid or not, or hypothyroid or not. So this is basically based on the serum TSH. The first investigation in case of goiter is serum TSH, and if serum TSH is low, then these are the differentials: subacute thyroiditis and hyperthyroidism. And subacute thyroiditis, wait and watch is the treatment. Only symptomatic treatment is needed, like painkiller, NSAIDs or steroids for the treatment of pain in the neck region, and the beta blocker for the treatment of the symptoms like palpitation, tremor, etc. And after some times wait and watch, and patient becomes, in most of the cases, becomes euthyroid. In case of hyperthyroid, initial antithyroid drug and followed by the radioiodine or surgery. But a few years before, the radioiodine was the very popular treatment for the treatment of hyperthyroidism. After initial controlling of the hyperthyroid phase, most of the physicians recommend radioiodine treatment. But nowadays, the antithyroid drug, the role of antithyroid drug for the treatment of hyperthyroidism is become more accepted, and in most of the situations, antithyroid drug should be the initial treatment of choice, and the duration depends on there are various controversies regarding the duration of the treatment with antithyroid drugs. According to some school of thoughts, 18 months of antithyroid drug is sufficient. According to some of the school of thoughts, it can be extended up to 2 to 3 years, and according to some school of thoughts, it can be given up to the 5 years. So with the outcome of these antithyroid drugs after giving antithyroid drugs for 18 to 24 months, in almost 1/3 of the patients there is remission of the hyperthyroidism, but in 2/3 of the cases there is no remission. And when give these antithyroid drugs for the longer duration means more than 5 years of the 5 years with treatment with antithyroid drugs, then the chances of remission is high. Up to 50% of the patients can go into the remission with longer duration of treatment with the antithyroid drugs. So this is all about the hyperthyroidism. Now the second scenario is we do TSH. After doing TSH is high. So this is a case of hypothyroidism. So hypothyroidism treatment is very simple. Levothyroxine replacement is the treatment, and levothyroxine, the dose should be 1.6 to 1.8 microgram per kg of body weight, and this type of patient should be followed by the serum TSH level, and serum TSH should be done every 6 to 8 weeks, and depending on the serum TSH level, the levothyroxine doses either can be up titrated or down titrated, or can be maintained up at the same dose with the same dose. So the in hypothyroidism, there are two types of hypothyroidism. First is the primary hypothyroidism and second is the secondary hypothyroidism. Primary hypothyroidism, T3, T4 are low and TSH is high. In secondary hypothyroidism, primary hypothyroidism means disease is confined into the thyroid gland. Secondary hypothyroidism means disease is somewhere else. It is not confined to the thyroid gland. And then whether disease is confined, then it is confined into the pituitary gland. So due to pituitary disorder, less TSH is produced and this less TSH is causing hypofunctioning of the thyroid gland, then this is known as the secondary hypothyroidism. So all the signs and symptoms of hypothyroidism is present in secondary hypothyroidism also, but some lesser extent manifestations are present in cases of secondary hypothyroidism, because some amount of thyroid hormones even are produced even in the absence of the TSH by the thyroid gland. So manifestations are less severe in cases of secondary hypothyroidism, but whenever there is secondary hypothyroidism is present, then our duty is to define whether it is an isolated secondary hypothyroidism or it is this secondary hypothyroidism is associated with other pituitary hormone deficiencies. Most commonly, isolated secondary hypothyroidism is a rare disorder. In most of the situations, isolated this secondary hypothyroidism are associated with either adrenal insufficiency or either growth hormone or multiple pituitary hormone deficiencies. So in that case, in cases of secondary hypothyroidism, we have to evaluate for the other pituitary hormone function to know the status of the other pituitary hormones is also very necessary, because most common association is secondary hypothyroidism associated with the secondary hypocortisolism. So in that case, if both patient is having both secondary hypothyroidism and secondary hypocortisolism, and if you have not evaluated for the secondary hypocortisolism, and based on second reports and clinical features, and if you started levothyroxine replacement, in that case, patient might land into the adrenal crisis state. So so that's why evaluation of the hypocortisolism is also very important. And if both secondary hypothyroidism and secondary hypocortisolism are present, in that situation, the cortisol replacement or steroid replacement should be initiated first, and then levothyroxine replacement should be started later on. So this is all about the hypofunctioning of the thyroid gland. And so So all these slides are discussed by the previous speaker, so I have not discussed this. So in summary, evaluation of thyroid gland, whether thyroid nodule is detected clinically or incidentally or imaging, the first investigation should be the TSH, and after TSH the second investigation should be the USG thyroid, and based on TSH, if TSH is normal or elevated, then there is no need to do sonography or later evaluation. And if TSH is subnormal, then the next investigation should be radionuclide scan, and based on radionuclide scan we can define that this is a case of subacute thyroiditis. If there is either minimal uptake or no uptake in the thyroid gland, then this is a case of thyroiditis, subacute thyroiditis, and based on radionuclide scan we can define this is a case of Graves' disease, or this is a case of toxic adenoma or toxic MNG. When wild hyperthyroidism is present, then we have to treat. So this is all in summary the treatment of hypothyroidism and hyperthyroidism. I have basically given talk based on my previous knowledge. I have not made slides because I have made slide on the evaluation of thyroid nodule, but already discussed by the previous speaker. So I have left that slide intentionally and speak by my previous knowledge. Any?
Okay, thank you, Dr. Ved, for nice presentation. You have tried whatever difficulty in day-to-day practice people suffer.
And now house is open. If anyone has any question, you can put.
This is of subclinical hyperthyroidism. So in many patients, the TSH level is between 5 and 10, and many times those patients doesn't need treatment. So what is the basis? And some patients in our OPD also with say cancer cases, they also come with 25, 50 or 50 to 100 level of TSH with normal T3, T4. So what is the criteria in those patients, how to treat, how to follow, how to titrate the drugs? And if we have to see the thyroid also for any nodule in those subclinical hyperthyroidism.
Basically, subclinical hypothyroidism by definition, T3, T4 normal and TSH between 5 to 10 or just above the upper normal range. So this is by definition subclinical hypothyroidism, and as the name clearly says that subclinical means there are no clinical symptoms present. And since nowadays thyroid function is a routine clinical investigation done in most of the OPD patients, and so the incidence of subclinical hypothyroidism is very high, even more than overt hypothyroidism. So question arises whether this type of patients subclinical hypothyroidism should be treated or not to be treated. There are some indications. There are different school of thoughts, but the summary is that there are some indications for treatment of subclinical hypothyroidism in general population. And what are those indications? The first indication is if any child presented in the growing age between 5 to 15 years of age with subclinical hypothyroidism, it can be treated. Why it can be treated? Because in that case, if you are giving by levothyroxine therapy, if patient gains even 2 to 3 centimeter of height, that can be very beneficial. So in growing age, subclinical hypothyroidism should be treated. The second indication is you have to test the autoantibody status. If anti-TPO antibody is present in the high titer, positive in the very high titer, then anti-TPO antibody what indicates? Anti-thyroid peroxidase antibody. Thyroid peroxidase enzyme is responsible for the thyroid hormone synthesis. So sooner or later, these high anti-TPO antibody titer positive patients will convert into the hypothyroidism, overt hypothyroidism. So in that scenario, in that case, you can treat subclinical hypothyroidism. If any female patient presented with the menstrual irregularity or patient presented with the infertility, in that case, in cases of infertility, there is clear-cut indication for treatment of subclinical hypothyroidism. There is no doubt. In menstrual irregularity, it is controversial whether to give levothyroxine therapy or not to give. But since we do not, we endocrinologists usually do not treat for the menstrual irregularities, but most of the gynecologists usually started treatment. So there is no harm in giving treatment because levothyroxine is a very safe drug, the safety margin is very high. Unless until you over-treat, there are no side effects of levothyroxine therapy, so you can treat. So these are the 3-4 main indications of treatment of subclinical hypothyroidism. And the fourth indication is if any patient is of coronary artery disease. So in studies it has been found that even subclinical hypothyroidism is associated with dyslipidemia, increased cholesterol level, increased LDL level. So if any case of there is coronary artery disease, in that case you have to also treat subclinical hypothyroidism.
Enthusiasm and valuable knowledge. Now I would request Dr. Fatima to come up on the stage with the memento, and I will request our chairpersons to please felicitate our speaker. I would like to request Dr.
थैंक यू सर। फिर हमारे सेशन 4 की शुरुआत है। डॉक्टर राकेश कुमार सिंह, हेड ऑफ डिपार्टमेंट ENT डिपार्टमेंट IGIMS, प्लीज कम ऑन स्टेज एंड हैव अ सीट। डॉक्टर मुकेश कुमार, एडिशनल प्रोफेसर इन डिपार्टमेंट ऑफ जनरल सर्जरी, प्लीज कम ऑन स्टेज एंड हैव अ सीट।
Dr. Amit Patel, sir, Senior Consultant, Surgical Oncology, Bihar Cancer Surgical Hospital, Patna. Dr. Reba Ephraim, Assistant Professor, Surgical Oncology, AIMS, Patna. Please come up on the stage and take your respective seats.
Sorry to inform, but probably Dr. Mukesh is not available. I will call Dr. Nadeem from Department of General Surgery. Please come on stage and have a seat.
Chief Sharan, sir, Head and Neck Oncosurgeon, HCG Echo Cancer Center, Kolkata, on the topic Surgical Management of Thyroid Carcinoma and video presentation of minimally invasive thyroidectomy. Sir, please come up on the stage.
Good afternoon, everyone. I would like to thank Department of Surgical Oncology, Indira Gandhi Institute of Medical Sciences for organizing this thyroid update on occasion of anniversary celebration of Operation Theatre. Big congratulations to all the team. I would like to thank Dr. Manish and whole of organizing team for inviting me for this talk. I am going to speak about surgical management of thyroid cancer and video of remote access thyroidectomy. We'll show you a video. So I will be just focusing on differentiated thyroid cancer because I thought from the schedule no pathologist or nuclear medicine talk was there, so I just little bit added those talks, but already Dr. Arnava has covered very nicely about nuclear medicine part, so I will skip those slides. So surgical anatomy, as Dr. Azhar has shown in the morning, so this picture give you what you require to be confident in thyroid surgery. So this is recurrent laryngeal nerve, this is external branch of superior laryngeal nerve, and these are the two parathyroids. Because all your complications of thyroid surgery are related to these all four structures here. So if you damage this recurrent laryngeal nerve, patient will have bad voice, and permanent damage that occurs only in 1%, around 1% of cases only. 99% you can preserve this nerve. Similarly, superior laryngeal nerve, that will give intensity of our voice will not be there. And these two parathyroid gland, these are very, very important structures, very small one, but if you don't preserve these parathyroids, patient will have long life, whole life morbidity of hypocalcemia. Patient has to be supplemented with calcium tablets and vitamin D, and even with those medicines sometimes it creates problem in those patients. So according to me, most of the time nerve you can preserve, but parathyroid if you don't preserve, that is not acceptable for the patient because that is associated with very bad morbidity for the patient. So I will be discussing mainly papillary thyroid cancer and follicular carcinoma, and age is very, very important factor in management of thyroid cancer. If patient is younger than 45 years, then only 2 stages will be there, even with metastasis that comes under stage 2, because survival is very, very good even with metastasis in those patients. So what will you do when 30 years old lady presents with thyroid nodule? How will you proceed? So most important, as my previous speakers very nicely explained about role of TSH as well as TSH, so that determines what kind of lesion or disease you are dealing with. Apart from TSH, ultrasound is very, very important, and ultrasound guided FNAC will give you type of cancer you are dealing, and all those patients are going for thyroid surgery should have laryngoscopy to see vocal cord movement. That is also very, very important, so that pre-operative assessment of laryngeal function can be done. MRI and CT scan mainly for bulky disease or fixed disease, fixed nodule, retrosternal extension or multiple nodes are there. So in those cases better to do
objective imaging like CT scan or MRI, you can see, assess, and accordingly you can plan your surgery. With ultrasound, that is subjective imaging, the radiologist will know where location of the nodes are there, exact location you will not be sure. So MRI and CT scan give you better pictures of nodal stations, and accordingly you can deal with those stations. Papillary carcinoma is the most common cancer. It accounts for almost 80% of all thyroid cancers. Mainly age ranges from 30 to 40 years. Female has more incidence, almost double the incidence in male. And pathology by orphan NI cells, you can see samoma bodies can be seen. And most of papillary carcinoma, thyroid cancer is multifocal, and lymph node metastasis is quite common in these cases. So this is SEER database. You can see from this graph, almost 98-99% of patients will be surviving for 5 years or even 10 years. So all these patients will have almost normal life if you can avoid the morbidities of surgery. So that's why I was mentioning previously, parathyroid preservation is very, very important in thyroid surgery. Otherwise, patient will have problem of hypocalcemia whole life. So what are the goals of initial therapy of any differentiated thyroid cancer? To remove the primary tumor and nodal metastasis, minimize the risk of disease recurrence and metastatic spread, to facilitate radioiodine treatment if required, permit accurate staging and risk stratification of the disease, minimize treatment related morbidities. So ATA guidelines 2015, that is still has not been updated after that, recommends less aggressive treatment for low risk papillary thyroid cancer, and central compartment nodal excision is optional for low risk papillary thyroid cancer because of risk of hypocalcemia, hypoparathyroidism due to central compartment excision. So this is latest NCCN guidelines, and if your FNAC showed papillary carcinoma or suspicious for papillary carcinoma, then, and if nodule is less than or equal to 1 centimeter, there are no neck nodes, in that case active surveillance with just only ultrasound is also an option. With lot of studies are coming on this one, active surveillance in thyroid cancer. And there are exceptions to this one. So if nodule is located in the tracheoesophageal groove, or that nodule is abutting trachea, in those cases active surveillance is not an option, because if disease grows, then it can involve the structures in those regions, critical structures like tracheoesophageal groove that can involve the recurrent laryngeal nerve or trachea. So in those cases, lobectomy is just simple lobectomy with hysterectomy is treatment of choice. If nodule is more than 1 centimeter, in that case, what are the indications of total thyroidectomy? If any of these are present, so known distant metastasis, extrathyroidal extension, tumor more than 4 centimeter in size, if any nodes are there, or lesion is poorly differentiated, or there is a history of prior radiation exposure, or bilateral nodules are there in the thyroid lobes, in those patients total thyroidectomy is required. If all, here you can see these, if all these criteria are met, in those cases lobectomy is also an option, and these criteria include no prior radiation exposure, no distant metastasis, no lymph nodes, no extrathyroidal extension, and tumor size between 1 to 4 centimeter. So in these cases, both options of lobectomy versus total thyroidectomy, both options are there. And if you have done lobectomy for any nodule or for papillary carcinoma thyroid, and if you see any of these features, then patient will require completion thyroidectomy. That includes tumor more than 4 centimeter in size, gross positive margin, gross extrathyroidal extension, confirmed nodal metastasis, confirmed contralateral disease, and vascular invasion. So if any of these criteria are met, in those cases patient will require completion thyroidectomy, and if any of these criteria like lymphatic invasion, macroscopic multifocal disease more than 1 centimeter in size and poorly differentiated, you have still options of just following up these patients in follow-up. But if all of these criteria are met, negative resection margins, no contralateral lesions, tumor less than equal to 4 centimeter in diameter, no neck nodes or NIF-VTP, in those cases lobectomy is sufficient and patient can be followed up for in these cases. So when do you do therapeutic neck dissections? When involved compartments for clinically apparent or biopsy proven disease is there in the neck node. So if any suspicious nodes are there on the ultrasound or on CT or MRI, in those cases if you can do FNAC, ultrasound guided FNAC, and prove that these nodes are involved, in that case patient requires lateral neck dissection. Or even if like imaging criteria wise that looks suspicious, in those circumstances patient requires neck node dissection. And if nodes are positive, then level 2 to 4 neck dissections or 2 to 5 neck dissections can be done in most of these situations. Central compartment clearance, lot of studies have suggested a possible role of lymph node metastasis from papillary thyroid cancer in reducing patient survival. In a this is CA database study of more than 11,000 patients, Kaplan-Meier age stratified subgroup analysis found age more than 45 years to be associated with a higher mortality rate. In particular, 4-year disease-specific survival was significantly worse for patients more than 45 years old with positive nodes. So if we want to do central compartment, so this one here you can see this is the boundary of central compartment, hyoid bone to suprasternal notch and carotid on both the sides. So these includes, as Dr. Azhar has mentioned, anatomy of central compartment. So these includes prelaryngeal, pretracheal, paratracheal nodes. So indications, what are the indications for prophylactic CND? This is controversial, but generally recommended for high risk cases, especially for large tumors, extrathyroidal extension, male patient, age over 45 years and multifocal disease. All patients undergoing thyroidectomy for papillary thyroid cancer have intraoperative inspection and palpation of the central compartment, and possible benefits to reduce recurrence must be balanced with risk of hypoparathyroidism. So just only sake of completing the central compartment should not be done, because these can be associated with hypoparathyroidism, and if you have not much experience of doing central compartment, in those cases better to avoid or omit central compartment dissections, because otherwise you will give morbidity to the patients in the post-op. So indications for therapeutic central compartment neck dissections: when nodal metastases are present clinically or radiologically in central compartment, clinically involved lateral neck lymph nodes, recurrence in central compartment. So these are indications for therapeutic neck dissections. So briefly I will just mention about follicular carcinoma. So it accounts for around 10% of carcinoma thyroid. Mean age is 50 years in comparison to papillary thyroid cancer. It occurs in older age group. Again, female has more incidence of follicular carcinoma. For pathology, for diagnosis of follicular carcinoma, capsular and vascular invasion is required to confirm the diagnosis of follicular cancer. Distant mets is mainly through vascular route, lung, bone and liver. Definitive pre-op diagnosis is difficult because FNAC will not give you diagnosis of follicular carcinoma. So FNAC will show you follicular neoplasm, and based on those findings you have to go ahead with the surgery or further treatment. So there are molecular markers tests are there. So especially for follicular lesion, or you can say Bethesda 3 and Bethesda 4 lesions. So there are different sets of tests. So first is 7-gene MT test, is a rule-in test. So that confirms chances of malignancy in thyroid nodule. Other is GEC test that includes 140 genes, that is rule out test, and Thyrosec2, that is both rule in and rule out both tests. And here you can see this table. So if you take Bethesda 3 category, follicular lesion of undetermined significance, and if GEC is benign, then only 5% risk of malignancy will be there. So that is quite confirmatory, like if you want to follow up based on these lesions, that is also one option. And if you can see 7 gene empty test is positive, then 88% chances of malignancy will be there in those nodules. So better to go for surgical management of those nodules. And if you can see Bethesda 4, GC, if it is suggestive of benign, then only 6% chance of malignancy. And if 7 gene empty test is positive, then 87% risk of malignancy. And Thyrosec2 panel, if it is positive, then 87% chances of malignancy. So if 7 gene empty test and Thyrosec are positive, so that indicates high risk of malignancy in those nodules. So those nodules should be treated surgically. So this is NCCN guidelines for follicular carcinoma, and if you get a FNAC report of follicular neoplasm, that is Bethesda 4, then there is an option of total thyroidectomy if radiographic evidence of intraoperative finding of extrathyroidal extension or patient preference. If patient wants to get rid of all of his thyroid and doesn't want to go for another surgery, in those cases total thyroidectomy is an option. And if lobectomy or ischemectomy can be done for these patients with follicular neoplasm, but patient should be told that if any of bad prognostic factors come in the final report, then patient has to undergo for completion thyroidectomy. And if invasive cancer, widely invasive or encapsulated angioinvasive with more than equal to 4 vessels, then patient will require completion thyroidectomy. Only encapsulated angioinvasive with less than 4 vessels or minimally invasive follicular thyroid cancer, in these patients, patient can undergo completion thyroidectomy or patient can be kept on follow-up. But if it is only benign or NIFPT, in those cases just only follow-up can be done. So post-op radio iodine, I think he has covered very nicely. So mainly indicated for stage 2, 3 and 4, most patients with the stage 2 disease, 45 years or older, and with the stage 1 disease, especially with multifocal disease, nodal metastasis, extrathyroidal or vascular invasion or more aggressive histology. Thyroid suppression, ideal dose to titrate with TSS for low risk disease, it is between 0.1 to 0.5, and for high risk disease is less than 0.05, that is recommended TSH range. Follow up, as Dr. Arnava has already mentioned. So I will just show you a few scenarios. So this is CA thyroid, advanced thyroid cancer with involvement of the skin. So patient required total thyroidectomy with central compartment with excision of the skin. Here you can see, and here you can see this rotation flap has been done, and intra pictures after resection of the tumor, you can see the recurrent laryngeal nerve, and you can see here vascularized inferior parathyroid here, and this is superior parathyroid here. This is another 55 years old lady with she came with hemoptysis for last 2 years. She was under care of pulmonologist, and some 2-3 sessions of laser treatment was done, but I think he didn't see the thyroid mass sitting here and involving thyroid, the trachea. And here you can see, this is a bronchoscopic picture. You can see the mucosa, tracheal mucosa was involved, and here you can see this thyroid, this mass is here, and that was involving almost 2 tracheal ring 2 to almost 8, 9, almost 7 rings. So that almost more than 4 centimeter of trachea was excised, and trachea was mobilized from the mediastinum, as well as suprahyoid muscles was released to do primary anastomosis here. You can see this we achieved primary anastomosis of trachea, and here you can see the tumor and large segment of trachea. Day 7, here you can see the anastomotic site is healing well. This is another case, CA thyroid involving pyriform sinus. So here either one option is to do laryngectomy, but because that involvement was not that much and that was mainly involving pyriform sinus, so we just opened the larynx, we resected the disease with margin, and we did primary closure of the pharyngeal mucosa. And here you can see a strap muscle patch was put over the anastomotic site. Patient had normal voice and normal function later on. Here, lot of times recurrent laryngeal nerve either can be involved with a tumor encased, or it can be involved by the lymph node. So here you can see thyroidectomy was done, but small node that was sitting on the recurrent laryngeal nerve. So that nerve was totally like entrapped by the tumor. So what we did is always, like recurrent laryngeal nerve, always try to save unless it's involved completely. So in this patient we under microscope magnification with micro instruments we were able to take out the nerve sheath and preserve the nerve fiber. Here you can see this node was excised from here, and this nerve still was intact, and patient had normal voice in the post-op. So for parathyroid identification, because that is the most trickiest part for any even experienced surgeon, sometimes it's very difficult to identify. Everything will look like, and especially thyroid cancer patient, when lot of nodes are there in the central compartment, it's very difficult to identify parathyroids in some situations. And so there are methods to identify that one. One is near infrared autofluorescence of parathyroid, and other is ICG dye. So here you can see this is all looking like fat here, 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 here. So it's sometimes difficult to identify the actual parathyroid. So in those circumstances you can inject ICG dye, and after 20 or 30 seconds you can start seeing the color under infrared camera. Here you can see this parathyroid is bright green. So here this one was the parathyroid in this patient. Nerve monitoring, because now this is still controversial, lot of meta-analysis has been done and very few meta-analysis has shown benefit of nerve monitoring, but difficult situations it's definitely beneficial for the surgeon. That gives you confidence to identify the nerve and accordingly complete the surgery. So here you can see this nerve monitoring system has a special tube, endotracheal tube with electrodes, surface electrodes that will be in touch with the vocal cord, and 2 electrodes in the chest, and with these you can stimulate the nerve, and here you can see the graph, intraoperative graph, you can see a good voltage here for both the nerve. So in those patients you can be sure that patient will have almost normal voice in the post-op. Here you can see post-op laryngectomy, laryngoscopy showed normal function, vocal cord function. This is nerve grafting. When nerve is totally encased, like here you can see a big tumor, nerve, recurrent laryngeal nerve is totally encased by the tumor. So here you can't dissect the nerve and preserve that one because this is totally involved. So here you have to cut the nerve, sacrifice the nerve, but in these situations you can do nerve grafting from either greater auricular or some of ansa cervicalis, ansa hypoglossai. You can take those nerve and do end-to-end anastomosis. This is, here you can see the nerve graft, and under microscope with micro instruments you can anastomose this nerve graft. So patient will not have normal movement of the vocal fold, but patient that will anastomosis will prevent the atrophy of vocal fold, and patient will have better voice than if you don't anastomose, don't do nerve grafting. Parathyroid autotransplantation. So if you accidentally remove the parathyroid, or if your parathyroid looks devascularized, in those cases better to take out those parathyroid, confirmed by frozen section, do multiple pieces like this one, and then put in pockets of vascularized sternocleidomastoid or any muscles that should be vascularized. So after 2 to 3 weeks, patient's calcium will start improving. This is recurrent papillary thyroid cancer, 55 years old male, follow-up case of papillary thyroid cancer, post-total thyroidectomy and post-radioactive iodine. Developed central compartment recurrence after 2 years of follow-up, FNA was positive, iodine scan was limited disease. So here you can see the node here. So we went ahead and dissected the node. So because even if you give radioiodine, that is not going to work with larger nodes. So these patients require surgery, and post surgery you can go for radioiodine in these patients. So little bit of minimal remote access thyroidectomy. So we are always worried about change in voice, recurrent laryngeal nerve palsy and hypocalcemia, that is hypoparathyroidism, but we never give attention to scar, what patient undergoes in post-op period. So you can see sometimes scar will be good, but sometimes bad scar like this one also can happen, and these patients always try to cover their neck with some kind of dupatta or some ornaments or something, because they don't want to show and ask question, like wherever patient go, people will ask why, like what kind of surgery you have undergone. So stigma of cancer will be always there. So there are different methods to remove, like hide these scars in different areas. So these are called remote access surgery. This is not minimal access but remote access thyroidectomy, and that can be either done with axillary approach, or this is bilateral breast axilla, that is called Baba approach, face retroauricular approach. Here you can see these are the latest one. This is transoral thyroidectomy. So there are a lot of meta-analysis are there, and this is by Pan et al. 5,200 cases, and they have all meta-analysis had shown that surgical completeness including post-op radioiodine ablation rate is similar. Permanent hypocalcemia, vocal recurrent laryngeal nerve palsy, everything is equal. So oncological outcome is not compromised by all these remote access thyroidectomy. This is another meta-analysis, and they have proved that robotic or endoscopic thyroidectomy is as safe as open thyroidectomy based on long-term follow-up and surgical completeness, recurrence rate, and everything is all comparable with open thyroidectomy, but at the same time it gives better cosmetic satisfaction with remote access thyroidectomy. So I had opportunity to learn from master in this field. This is Professor Ko from Yonsei University, South Korea. He is a very good friend of mine. He is all world leader in robotic thyroidectomy, and I also learned from Professor Luong. He is from Vietnam. He has done maybe 6,000 of endoscopic thyroidectomy. So how do you do this endoscopic thyroid approach? Here you can see this is breast, axilla and breast. So 3 ports position are there. So 5 millimeter, 5 millimeter and 10 millimeter port will be in here. You can see these ports have been placed, 3 ports. CO2 gas will be connected, and with that creates your space in neck, and you can complete the procedure with endoscopic approach. So this was my first endoscopic thyroidectomy that was done in I think 2015 in Paras Hospital when I was there. So this one was the nodule, and this is post-op result. So you can't see anything in the neck, so stigma of cancer can be hidden, so patient will quality of life will improve. This is a 22 years old female, recently newly married, and presented with swelling in the neck for 1 month and noticed only in the in-laws house, and after that there was a crisis in the family because everyone was blaming her and her parents. I gave options of retroauricular endoscopic thyroidectomy, again done in Paras Hospital when I was there, and here you can see this nodule, almost 4 centimeter nodule was there in one lobe, and FNA was follicular neoplasm. So we did only hemithyroidectomy, and here you can see the post-op result. A scar is well hidden underneath the hair. This is another 25 years old unmarried female, a professional. presented with 3 centimeter nodule right lobe of thyroid with right neck nodes. FNA was papillary carcinoma thyroid, and her marriage was planned after 3 months. So we planned for retroauricular robotic approach, total thyroidectomy central compartment with right neck dissections, and here you can see this incision that retractor has been put and then robotic arms have been docked, and all the procedures can be completed with the help of robot. And this is here you can see this is the immediate post-op that takes lot of initially that used to take lot of effort from my side, but next day when you go to the ward and see nice all patients sitting in bed, that gives you much more satisfaction than your hard work. Here you can see this is after 2 months, so neck all looks beautiful, scar is well hidden, patient got married and very happy now. This is another approach. This is 55 years old lady presented with thyroid nodule. Ultrasound showed bilateral both lobe nodules. Ultrasound FNAC was follicular neoplasm. So this time we planned for robotic total thyroidectomy. This was BABA approach. Because this approach is evolving, so no approach is 100% perfect for all patients. So there are limitations with each approach. So that depends upon like what kind of approach you choose. So here you can see this is a normal position like what you do in open thyroidectomy with neck extension, and arms are just 90 degree, not more than 90 degree, because that will cause cervical plexus injury. And here you give 3 port like 8 mm incision on right one side and other 2 8 mm incision on the other side. But here from here you have to reach the neck, do like all normal flap raising in the neck, and you complete the procedure. So here you can see this is post-op after completion of surgery. So you can hardly see the scar, very small one, all 5 scar well hidden. And this is the video of robotic thyroidectomy BABA approach. So this is the patient. This is the normal position what I showed with neck extension and arms abducted at 90 degree. These are the port position. 5 ports have been put, one for assistant and other ports are robotic ports. So once you dock the arm, so 3 arms, one camera with 3 arms will be there. One is monopolar scissor, this is bipolar, this is retractor. So that acts as your assistant because you can retract whatever you want. So this flap raising is like normal open thyroid surgery. So this subplatysmal flap has been raised, and you are just separating the midline, strap muscles in the midline here like normal open thyroidectomy. So now thyroid lobe is being dissected. So that advantage of robotic thyroidectomy is this 3rd arm. That is not there in open like endoscopic thyroidectomy. So this one is more comfort, that gives more comfort for the surgeons. Everything you can control from the console. So all perithyroid dissection is being done. This is lateral part of the thyroid lobe. Here you can see this is all branches of inferior thyroid artery. So here you can see this is parathyroid, all fat, looking like fat only. So here ICG you can see in the robot with firefly system. So this is inferior pole. So everything is done by bipolar and monopolar, so there is no need for taking sutures or clips. If required, you can put clips through assistant port. So here you can see branch of inferior thyroid artery. So here you can see this was the nerve, recurrent laryngeal nerve here. So here you can see what this is inferior parathyroid, and you can see the branch of superior inferior thyroid artery coming in the parathyroid. So if you ligate or buzz this vessel, then your parathyroid, inferior parathyroid will be devascularized and will be dead. So you have to preserve the parathyroid based on the intact vessels. Here you can see this is the recurrent laryngeal nerve here. So what Dr. Azhar was mentioning was ZT, Zuckerkandl tubercle, and if that is there, so that makes surgeon's life difficult. But advantage of JT is if you dissect gradually, that will show you the recurrent laryngeal nerve and superior parathyroid. So recurrent laryngeal nerve will be just posterior to the ZT. So here this the thyroid is, this is berry ligament area, so that is being dissected over the trachea. This is the trachea here. So this one right lobe has been dissected. Now moving to the left lobe. This is left lobe. Now that left lobe is being mobilized. So here you can see this inferior parathyroid here. So this is under magnification 4 times or 5 times. So everything you can see, identify, and this in robot that vision will be 3D, so you have depth perception in that one. So here parathyroid, superior parathyroid is coming in picture here. So the last bit of tissue near berry ligament, here in recurrent laryngeal nerve of left side will come. Here you can see this is recurrent laryngeal nerve is coming in picture. This is superior parathyroid here with fat. So this one is superior parathyroid. So these are pre-laryngeal nodes you can include with the specimen. And here you can see, like in block thyroidectomy you can do. So other approaches, you have to divide the thyroid in midline so that you can remove the both lobes separately, but here in this approach whole of thyroid gland you can do like a normal open thyroidectomy. You achieve hemostasis. You can see here this is recurrent laryngeal nerve here, superior and inferior parathyroid here. And this is you orient the specimen. Then you put a plastic bag so that contamination should not be there in the tract. Drain is put, and this is an block specimen of thyroid. And this is post-op, immediate post-op after closure of all the wounds. And a scar you can see. Here you can see this is post-op picture, so everything is fine, no scar is seen. And this was pre-op and this was post-op pictures. Prognostic factor, one more slide. As I mentioned, age is the single most important prognostic factor. Lymph node status, gender, histology, size, exothyroid aspect, distant mets, and thyroglobulin level. These are all prognostic factors. To conclude, majority of differentiated thyroid cancer has good prognosis. Choice of surgical procedure should be tailored to oncological need of the patient. Less aggressive approach for low and intermediate risk thyroid cancer. Surgical morbidity should be minimal and related to experience of the surgeon. Remote access robotic endoscopic thyroidectomy is safe, equivalent, oncological outcome with better cost message. Thank you.
Nodule or thyroid cancer. You have mentioned about the active surveillance, and for that this one's genetic analysis, it is important, and second part is the follow-up. So we are our patients are struggling in both the field. We don't have any lab for the genetic analysis, and the follow-up is also a problem. So for our perspective, what is your opinion?
The genetic is obviously like we also not do much because these are very costly tests.
Yeah.
So that is like our average patient can't afford that one. So that is for documented documentation only. So routinely hardly very few patients will get this test done because that cost is too exorbitant. Regarding follow-up, that these thyroid cancer patient requires only 6 monthly follow-up initially, and then maybe after 1 or 2 years that can be followed up yearly, once in a year. So that follow-up is quite simple. These are like tests what Dr. Ajay, that Nava has mentioned. So mainly TSH, thyroglobulin antibody, maybe calcium you can get, and one ultrasound. So from these tests you can say okay whether patient is free of disease or not. So radioiodine scan for high risk patient we get after 6 months of treatment of radioiodine, but later on radioiodine is not required unless you suspect some recurrence. So with only TG antibody, ultrasound and TSH you can follow up these patients.
The basic problem is the missing patient. We have a lot of missing patients. Just we assume it is slow growing tumor. So this one's mortality is very low. 5 years survival rate and 10 years survival rate is very high. After one patient gets relaxed, the healthcare assessment is also not very accessible for them. So that is the reason of missing patient. And one day they come with a huge thyroid with a lot of metastasis in lung and everywhere. So is it possible in our scenario? Or better to do if we are getting a thyroid cancer in FNAC, just operate it?
No, so
what do you think?
How you counsel these patients? Because if I operate, so patient will be coming whatever I say. So patient come under follow-up. So that counseling is very, very important. Even if it's low risk disease, very low growing, very slowly growing disease. But once recurrence happens, then obviously that will cause problem for that patient. And that may be second surgery may be related with lot of morbidities because this is already operated neck. And if you have to do central compartment later on, so chances of hypocalcemia will
lot of scars, and in that scenario the preservation of parathyroid is very difficult.
Yeah, so that chances of hypocalcemia will be very, very high after
even that space which anesthetist is supposed to put the tube. So it is next to impossible, literally impossible to do a tracheostomy in a patient who has landed with a big mass, thyroid mass and with stridor.
So if you just tell patient to lie down, to come up, you have to keep shoulder back to extend the neck. So that is impossible for these patients. So many times I have to do in sitting position tracheostomy, but that too when I am sure that I will get the trachea. Otherwise I don't go for tracheostomy. I will just consult the patient. Yeah, already encased everything, or you don't know anything about the carotid vessels because that is all nearby structure. So everything will be encased by the tube.
It's a medullary carcinoma. Is there any role of prophylactic thyroidectomy in young patients? So what is your experience?
Yeah, so
what are that indications of prophylactic thyroidectomy?
Yeah, so first you do prophylactic thyroidectomy, but familial one, If patient like there is no calcitonin is normal, ultrasound wise nothing is there, in those cases I think we can just keep under close follow up. So you have to.
In terms of T or N stage, how do you bar that will not go for a minimal invasive surgery? That's one point. And second, sir, one of the slides you showed, there was a patient with a young lady with a 3 into 2 centimeter right lobe mass with a node N positive, and you chose to approach through a retroclavicular approach. I suppose you did a total thyroidectomy, sir. So, what's your take in between when you decide between will you doing a BABA or a rabbit or a retroauricular? How do you decide between them?
So if patient requires neck dissection, then I prefer to do retroauricular approach because your neck will be in front of you. So you can do neck dissection on the same side, same lobe lobectomy, and for other side you go from other side. So both neck, both total thyroid as well as central compartment, everything you can clear.
Central you can manage through retroauricular?
Yeah, yeah.
Okay.
So routinely I have done so many cases.
Oh, great.
I am doing routinely.
Great,
The
sir.
BABA approach, if nodes are laterally placed in those patients, that's difficult. So I have not done till now BABA approach neck dissection. So those patients I prefer to do with retroauricular.
Retroauricular. Great, thank you.
Yes, 6 generally you can remove, and advantage I generally try to do with endoscopic approach or even with open. I just try to put my scope there, try to create some space, and with harmonic newer energy modalities like harmonics and supra like ligashore, I can like lower part of mediastinum also can be clear, upper part, not lower part. Yeah, so superior mediastinum you can do that part. So most of the time with extension of neck that comes out, and if that is in continuation with the thyroid lobe, then it's easy to clear those nodes. And if that is not possible with just this only neck approach, in that case you do have to do sternotomy, mini sternotomy or proper sternotomy.
ये सूचना हम सभी के लिए बहुत ही ज्ञानवर्धक था। अब मैं चाहूँगी डॉक्टर बंटी प्लीज स्टेज पर मोमेंटो लेकर आएं और हमारे स्पीकर्स हमारे चेयरपर्सन्स प्लीज आप स्टेज पर आएं और हमारे स्पीकर को फेलिसिटेट करें।
I would like to request Dr. Richa Madhvi ma'am, additional professor, please come on the stage and felicitate our chairperson. Radiation Oncology at Paras Hospital, please come on the stage and take a seat. Dr. Kunal Kishore, Assistant Professor in Department of Radiation Oncology, State Cancer Institute, please come on the stage and take a seat.
Sir, Associate Professor, General Surgery, IGIMS Patna, please come on this stage. Dr. Sandeep Kumar, Sir, Senior Consultant, Surgical Oncology, Medanta, please come on this stage and take your respective seats.
Now I request Dr. Vanitha Trivedi, Head of Department at Radiation Oncology Department and Mahavir Cancer Sansthan, please come on the stage.
All of you. So we have learned till now that CA thyroid, for management of CA thyroid, surgery is the mainstay treatment, and if it is operable, and after surgery, it's depending upon the histopathology report, we have to refer patient for radioactive iodine ablation. So surgery is the mainstay treatment and there is no doubt about it. And what type of surgery? I think Dr. Rajiv Sharan has already told us when to go for lobectomy, when to go for total thyroidectomy. That all depends what size of the tumor is, what is the histology of the tumor, lymphatic invasion, vascular invasion, extrathyroidal extension, hai ya nahi hai, any lymph node is there or not. So these are the indications, various indications, whether you have to go for either lobectomy or total thyroidectomy. So surgery in the form of total thyroidectomy or lobectomy is the treatment of choice for differentiated carcinoma of thyroid, that is papillary or follicular, due to inherent ability to retain radioactive iodine, and radioactive iodine ablation is given to all cases of papillary and follicular when it is required. That all depends again with the size of the tumor and the histopathology report. You have to see whether patient requires or not. But there are certain thyroid malignancy like anaplastic CA thyroid, medullary CA thyroid, which never concentrate radioactive iodine. So you should never send medullary carcinoma or anaplastic carcinoma thyroid for radioactive iodine ablation once surgery is being done, because they never concentrate radioactive iodine. So surgery and radioactive iodine ablation, the mainstay treatment for differentiated CA thyroid. Is there any role of radiation? So, as Dr. Arnav told us, there are certain situations where radioactive uptake, we are asking for radioactive iodine ablation and it is refractory. So all those unresectable gross residual disease in the neck which is refractory to radioactive iodine, then you cannot do anything. Unresectable loco-regional recurrence. Suppose you have treated a case and there is a loco-regional recurrence, and that too unresectable. So what is to be done? So again, there is a role of radiation, especially all refractory to radioactive iodine. However, no prospective controlled trial till date have been completed using external beam radiotherapy for localized CA thyroid in adjuvant setting. But we do have institutional some studies, we do have some retrospective analysis to show that adjuvant radiation in high-risk cases after surgery decreases the chances of local recurrence and improves recurrence-free survival in a patient of high risk, especially age more than 40 years and with lymph node involvement and with stage T4 disease. T4 disease means involving of adjacent structures. So this was another study which also highlighted that surgery is the mainstay treatment, but EBRT has got a role in adjuvant setting following surgery in high-risk patient and in unresectable cancer. But we don't have prospective randomized trial, and that is the reason in adjuvant setting, I won't deny that surgery followed by radioactive iodine ablation is the standard of care, but I will not say that it is a radio-resistant tumor. If you add radiation in all those refractory cases, definitely the chances of local regional control increases. In metastatic setting, I think every month 2 to 3 cases we get where the CA thyroid comes and patient has got bone metastasis, brain metastasis. So what is to be done? Again, in brain metastasis, if the lesion is solitary or limited CNS lesion is there, again there is a role of neurosurgical resection, but stereotactic SRS and SRT can also be given to such cases. And for multiple brain metastasis, usually we give whole brain radiotherapy. Either we give 30 in 10 fraction, 45 in 25 fraction, provided the performance status is good. As far as bony metastasis also, there is a role of palliative radiation. Now coming to medullary, as I told you, medullary and anaplastic, they don't take radioactive iodine, they are resistant, they are refractory. So in the medullary carcinoma thyroid, inability to concentrate radioactive iodine, hence no role of radioactive iodine therapy, but radiation therapy can be given in selected cases with extrathyroidal extension, extensive loco-regional nodal involvement and when after surgery you find there is a positive microscopic margin. R1 resection is done, margin is positive, extensive nodal metastasis there or extrathyroidal extension, we add radiation, and this is our institutional protocol also to add radiotherapy for all cases of medullary carcinoma when you find all high risk cases. Again, in medullary also there is a metastatic setting. In case of bone metastasis, in case of brain metastasis, we give radiation to those metastatic sites. And this was a systematic review which was published in 2019, which highlights the role of external beam radiotherapy. The highlights of this paper is post-operative radiotherapy reduces the risk of loco-regional recurrence in high-risk diseases. Those with extrathyroidal extension or involved nodes are at greatest risk. Dose of at least 60 gray should be given with IMRT, which is more effective, more conformal. Radiotherapy planning should be done. And the timing of radiotherapy is also very important. Radiotherapy should start within 6 to 8 weeks of surgery. So this is very, very important. You should not wait 3 months ke baad denge. You should start as early as possible. So this is about medullary carcinoma. Now coming to anaplastic CA thyroid. As we all know that anaplastic has got a very, very grave prognosis. The median survival is 5 months and the 5-year survival is very, very dismal. And majority of the patient, when they turn up, they are extrathyroidal anaplastic carcinoma thyroid. And once anaplastic CA thyroid is confirmed, you have to assess for the resectability. Always surgery. If it is intrathyroidal, please send to the surgeon, go for surgery. But all those cases, when you find that it is unresectable, then definitely radiotherapy combined with chemotherapy definitely improves short-term survival. ऐसा नहीं है कि anaplastic है, surgery नहीं होगा, then ask patient to go back home. There is always and we have found good result. I have treated a lot of cases of anaplastic CA thyroid. Surgery say refuse ho gaya because it is an extrathyroidal, going to the retrosternal extension, surgery is out of question. We have given radiation and we have found a good result along with concomitant chemotherapy. So radiation can also be given as salvage treatment as well as in palliative setting, and even there is a role of radiation in metastatic anaplastic CA thyroid. But the thing is that you have to take care of the nutrition. Enteral, kabhi-kabhi enteral feeding is required for the patient. You have to secure the airway. So this is very, very important. Securing, we asked also, tracheostomy agar ho pata hai, otherwise we have to take care of the airway also. So when a case is referred for radiation therapy, then what are the general principle any radiation oncologist should follow? So there is a case and you have to give radiotherapy. So the important thing is that you have to take care of the radiotherapy volume. So imaging is very, very important. Contrast enhanced CT or MRI, iodine total body scan, SPECT or FDG, PET and all. You have to take care of all these imaging if you have before you start target delineation. And whenever you delineate your target, what technique you are going to use, it's always conformal radiotherapy. Initially, when we had no linear excretor, we had cobalt machine in our department. We had treated a lot of cases with cobalt. But definitely if you have got the option of conformal radiotherapy in the form of IMRT, definitely IMRT is the preferred modality. I'll tell you why. Unresected or incompletely resected anaplastic CA thyroid, radiotherapy should be started as quickly as possible. And whenever, if R0 or R1 resection is done after anaplastic CA thyroid, adjuvant radiotherapy or chemoradiation should start as soon as possible as the patient is sufficiently recovered from surgery, ideally 2 to 3 weeks post-operatively. Don't wait, start as early as possible. You just see the patient has recovered well from surgery, you have to start with adjuvant treatment for anaplastic CA thyroid. So this was the initial field we were giving using cobalt, the whole of the neck area up to the level of superior mediastinum, as you can see. The whole of the neck region, taking into account the superior mediastinal, superior mediastinal always because that is a regional lymph node for CA thyroid. This was the portal, but now we are using a conformal radiotherapy in the form of IMRT. We can concentrate maximum dose to the area of interest. We can save the cord. We can save the bilateral parotid gland also. So this is the beauty of conformal radiotherapy planning. So always conformal radiotherapy should be planned so that we can reduce the long-term toxicity. So Now, how will you delineate target volume? So, in those cases, the important thing is that you have to take care of where is the gross residual disease. So, this is your GTV, gross tumor volume. What you will see on imaging is gross tumor volume. And then we give a margin of 0.5 to 1.5 centimeter so that we can create CTV, that is clinical target volume. And all the post-op cases you are taking, then the entire thyroid blood and any residual disease which is delineated by surgical clip should be taken into a clinical target volume. And planning regional lymph node can be included if it is involved, and sometimes we even take into consideration some elective lymph node volume is also taken where we delineate as CTV dose. And then planning target volume of 0.3 to 5 mm margin is added to CTV depending upon the technique and the image guidance that you are using. Now what about the dose and fractionation? So if you are using for the adjuvant setting, at least dose to 60 to 66 gray has to be given for all R1 resection microscopic disease there. 66 gray has to be given at a dose rate of 1.8 to 2 gray per fraction. If you are treating elective nodal region, dose of 50 to 56 gray is sufficient. And when you are using R2 resection or inoperable patient, dose up to 70 gray is justified. So this is the dose and fractionation that we use. For all gross disease, a dose of 70 gray can be given. For all R1 resection microscopic disease, a dose of 60 to 66 gray is good. And if you want to treat elective nodal region, then the dose of 50 to 56 gray at a dose rate of 1.6 to 2 gray per fraction can be given. So this is the guideline. Now coming to palliative radiotherapy of metastasis, if there is oligometastatic disease and good performance status, then we can use a high dose of 45 to 60 gray, and stereotactic body radiotherapy is also an option for oligometastatic disease. And widely metastatic disease, again you can give 8 gray in single fraction, 20 gray in 5 fraction, or 30 gray in 10 fraction, which is used very commonly. For brain metastasis, you have to choose whether there is a solitary metastasis in the brain or you are treating oligometastatic lesion in the brain. And if it is less than 4 or 4, you can either consider for SRS or you can go for surgical resection. And if there is a multiple metastatic disease in the brain, then only whole brain radiotherapy with or without hippocampal avoidance, or you can give 45 in 25 fraction at the dose rate of 1.8 gray per fraction. So this is a case of solitary cerebellar metastasis where stereotactic radiosurgery, I think this is not working. Oh. Stereotactic radiosurgery was given. As you can see, the lesion is in the brain where stereotactic radiosurgery was given, and the dose, that all depends what is the size of the tumor which is there, that all depends what is the size of the bone, lesion in the brain. So this is the whole brain radiotherapy, and you can see you can spare the both right and left hippocampus. If you are planning with IMRT and if you have got MRI facility to delineate your hippocampus, definitely we can spare hippocampus in giving whole brain radiotherapy, provided you are expecting long-term survival and the patient general condition is good. So this is the beauty, I told you why not to do 2D planning. As you can see in this 2D planning, this one is better or this one is better. Everybody will say that this one is better because you are sparing these are the normal structure. When you are treating this spinal metastasis, when you are using 2D planning, you can see the whole of the dose is giving to both, normal area is also getting the dose. But when you are using conformal radiotherapy planning, then you can see that we are giving more and we are conforming the dose only to the target of area, target of interest. And so this is the stereotactic body radiotherapy, and the dose fractionation what we follow is this, that all depends whether you are giving 1 fraction, 2 fraction, and that depends upon the size of the lesion. So whenever this is the NCCN 2023 guideline, when you are treating anaplastic CA thyroid, always if the GC is good, please combine your radiotherapy with the chemotherapy, and these are the radiosensitizing chemotherapy regime which should be followed in the form of paclitaxel, carboplatin, Taxol 50 mg per meter square IV, and carboplatin area under curve 2 weekly should be given along with radiotherapy. You can add docetaxel along with adriamycin 20 mg each weekly, or you can use only paclitaxel at a dose rate of 30 to 60 mg per meter square, or docetaxel 20, because these all act as a radiosensitizer and that will enhance the effect of radiation. So I'll end with some case scenario. So this was one case for 75-year-old lady with 1.5 centimeter medullary CA thyroid. Post total thyroidectomy was done. Microscopic resection margin was positive, but she was asked for resurgery to achieve negative margin. She refused, and then she was radiation therapy was planned in these cases. So this is another case scenario where after achieving microscopic resection margin, she refused re-surgery and the patient was advised for radiotherapy because there is no role of radioactive iodine ablation in this case. So whenever you plan your patient for radiation, you have to ensure adequate coverage of the thyroid bed into the superior mediastinum. You have to take pre-surgical anatomy and extent of surgery to delineate what will be your cranial and the caudal coverage of your target volume, and you should always take care that you have to adequately cover your surgical bed and scar as well as tracheoesophageal groove. As you can see, this is the tracheoesophageal, this is trachea, this is esophagus, and this is the groove. You have to take those areas also into account. So this is a second case where 59-year-old women with multiple recurrent papillary carcinoma tall cell variant, which is having a bad prognosis, with gross residual disease involving recurrent laryngeal nerve and left subglottic larynx after repeat total thyroidectomy and neck dissection. Again, this patient was referred since this is a gross residual disease even after second surgery. So you can see these are the gross residual disease which is delineated by surgical clip, because when we surgeons do and they suspect that there is a residual disease or microscopic disease will be positive, they delineate that so that it becomes easy for us to delineate where is the gross disease. So these are the red one that is marked, these are all gross disease, and we ensure adequate coverage of level 6 lymph node to the level of hyoid. We have to cover the superior mediastinal lymph node to the level of carina, because always up to the level of carina, that is T4 level, we have to cover superior mediastinal lymph node. This is again case 3, a 59-year-old man with multiple recurrent papillary thyroid post multiple surgical resection with unresectable. Now he has presented with unresectable locoregional recurrence and multiple mediastinal lymph node. So CTRT was given along with radiation with concurrent adriamycin was given in this case, and you can see the target volume that is being delineated. You have to take care of tracheoesophageal groove, you have to cover level 5. If ipsilateral lymph node is there on that side, you have to take care of, these are the red things that is marked, these are all gross disease which is there, and you have to spare the anterior scalene muscle. So these things are important, and you have to ensure adequate coverage of central compartment to the level of hyoid. And you have to ensure adequate coverage of all gross disease, thyroid bed, again superior mediastinum up to the level of carina, and if there is a gross node in the superior mediastinum, you have to boost those superior mediastinal lymph node if it is positive. So this is the last case, 79-year-old women with unresectable anaplastic CA thyroid that invaded trachea, that is invading trachea, that is invading the esophagus and all, where definitely no scope of surgery and definitive CTRT with concurrent adriamycin was given, and then you can see how well the target volume is being delineated. This is the gross tumor volume which is involved in the larynx. Esophagus is also involved. You have to cover the entire neck node. You can see the entire neck node, level 2, 3, 4, as well as 5. 5 is not included. 6 and 7 has to be included in this case. So this is the tracheostomy site should always be covered. Tracheostomy site should always be covered into your target volume when you are planning for radiotherapy, and you have to take care of the superior mediastinal node also in all cases. So the take-home summary is that we all will agree that surgery is the mainstay treatment, and followed by radioactive iodine therapy in papillary and follicular carcinoma thyroid when required. However, in recurrent and radioactive iodine refractory papillary CA thyroid, where radiation has got to role to play. In medullary carcinoma thyroid, adjuvant radiation, yes, can be tried if after surgery you find high-risk features like positive margin, multiple lymph node is there, or extrathyroidal extension is there. Definitely medullary carcinoma, if you add radiotherapy, definitely it improves locoregional control rate. In anaplastic CA thyroid, there is a role of adjuvant radiation with chemotherapy and definitive role when it is unresectable anaplastic CA thyroid. Palliative radiotherapy, everybody will agree that palliative radiotherapy, bone metastasis, brain metastasis, there is a role. And whenever you plan radiation, please try IMRT or IGRT for your planning, so that definitely we can reduce the toxicity and we can give more and more dose to the area of interest. So with this, I thank everyone. So this is the team of radiotherapy department at Mahavir Cancer Sansthan, and we all work together to get good result. And with this, thank you so much. Thank you all.
Wonderful presentation, Dr. Punita. It's dealt with all the topics related to all kind of astrology as well. Is there any question from the floor. Yeah.
Good afternoon, ma'am. I am a surgeon, that's why I am asking this question. As ma'am, you have told about that radiotherapy and chemotherapy is being given in the unresectable cases. So what are the survival rates like in medullary carcinoma or in the anaplastic when it is invading the trachea, and anything which is going on or it has been metastatic, then survival ratio for this one, and what are the follow-ups for that?
See, we don't expect long-term survival in these cases, especially when we are dealing with anaplastic. But overall short-term control rate is definitely we have seen cases of anaplastic. They have responded. Some of the anaplastic they did not respond to radiotherapy. So we have a lot of cases, some responding, some not responding. So, but since it is unresectable and there is no choice, surgery cannot be done, you cannot go for radioactive iodine ablation, the only choice left is radiotherapy. So we can try for all those young patients. We see young patients coming with anaplastic CA thyroid. And what is to be done? This is the radio, and we don't have data to see what will be a survival and how much will be the loco-regional control. As of now, we don't have any randomized control data also. But even for recurrent cases also, for differentiated, definitely we will ask surgeon to go for surgery. We will not add radiotherapy. All those, when the surgeon says, no, I cannot go for surgery, and you cannot send those patients for radioactive iodine ablation because refractory hai ya nahi le raha hai, ya already resistant cases to radioactive iodine. All those cases we can take. We have some institutional and retrospective studies by which we have shown that it can achieve some local control rate. But as of now, I don't deny the surgery and iodine ablation.
No, ma'am, this is not about the surgery or the radiotherapy. Like if the proper counseling is being given for the patient when if the patient is coming on. This is not about surgery or what. Like follow-ups are there, like we have to tell the patient 1 month follow-up, or if you have given the first cycle of the radiotherapy, chemotherapy, then after to come after the 3 days,
after 6 weeks,
3 weeks or something
we evaluate after 6 weeks. This is the normal protocol what we follow.
You got the point. See, for the anaplastic CA thyroid, you don't have any option. Surgery is the mainstay of treatment. Surgeons are refusing. Surgeons can't do the surgery. Definitely there is the role of radiotherapy to give them some kind of relief, symptomatic relief, quality of life, palliative benefits. Things are very important here. If you are, Vinita, one thing, see, how can we tell this the patient is resistant to radioactive iodine now? Is there any dose that has been given to the patient particularly and not responding to that?
I think
what is the maximum dose?
Limitation to certain dose. I think Dr. Rajiv Sharan will answer to this actually. I think 1,000 more, we cannot give a cumulative dose of more than 1,000 millicurie. Radioiodine. Cumulative dose.
500 they say, 500.
But I have read with 1,000, pata nahi.
After some time they can.
What is the literature share, Vinita, you are right.
I think
see,
I have read somewhere
800 to 1,000,
800
definitely we should think about, we should not give the further iodine ablation, and we should explore about the role of radiotherapy. One thing is very important, Dr. Vinita also has mentioned in NCCN guidelines as well there. SIV is very important in this case, once you are dealing with the radiotherapy in medullary CA thyroid. Because sometimes you need 50 to 56 grade to nodal area, and you need to give the more dose to the primary area. The SIV, if you are using, you are going to achieve in a good way, and that also suffices your 1.6 to 1.8 gray per fraction. So that is very important. I think she has covered excellent and wonderful way of radiotherapy in CA thyroid, and that is there. Is there any question now? One comment.
But there is a role of medical oncology also, because all those cases we give radiation and we refer to medical oncology because there is a role of tyrosine kinase inhibitors also in the form lenvatinib and sorafenib and cabazantinib is there. So these are the category 1 recommendation is lenvatinib as of what I know. So we refer all those cases to medical oncology because they have now medical oncology ka bhi acha, I think they are coming up with a good result for all those cases, जिसमें palliative setting or just for the local control, and I think they have also reported good result with using such molecular.
So you have to understand, just last comment, sir.
Your indications for adjuvant radiation in medullary carcinoma, it's completely excited.
Wonderful session. It was last but not the least session, and I invite Dr. S.K. Mondal to come on stage, and please our chairperson felicitate our speaker. And I would like to invite Dr. Dinesh Kumar Sinha, Additional Professor in Department of Radiation Oncology. Please come on stage and felicitate our chairpersons for the session. Sorry sir, देखे नहीं खा रहा. Okay. ये तुम बोल दो. शुरू करो.
Ladies and gentlemen, we have come at the end of the program. All the sessions were very insightful and enlightening.
तुम लोग भी आ जाओ बच्चा.
Pawar sir, Assistant Professor, Surgical Oncology, SCI IGIMS, to kindly come forward for putting forward the vote of thanks.
Thanks a lot, each one of you, for coming over here. We are thankful to our visionary director and chief, under whose guidance we perform this program. We are thankful to our chief guest and guest of honor who took their precious time out to spend some time with us and envision us. To our dean, to our MS, to our valuable speakers who took their time out from their personal engagements and came on to speak about today's program. We are thankful to all the chairpersons, to all faculties of SCI and IGMS, to students, staffs, and our patient. We are also thankful to Ankita and Preeti, who have performed very good moderation of this program. Thank you. Thanks a lot.
सभी गणमान्य अतिथियों और प्रतिनिधियों को धन्यवाद करना चाहूँगी. आप आज की जो तमाम जानकारियाँ साझा की गई हैं उसके लिए बहुत बहुत शुक्रिया. आप सभी का के यहाँ आने से निश्चित ही इस कार्यक्रम की शोभा बढ़ी है.
I would like to conclude the program with a Sanskrit verse, Annadanam Param Danam Vidya Danam Atah Param Annain Chanika Tripti Yajvin Cha Vidyaya.